ID बताना, email ID.
Can I request people who are not contributing to please mute yourself, sir? Kind reminder. I request all of you to mute yourself. Unless you want to participate in the discussion, please unmute and ask. Good evening, friends. Sorry for making you wait for beyond 8 o'clock. We had some challenges in setting up the PowerPoint. We have two important cases for today evening. We warmly welcome Professor Fiaz Hussain from Apollo Medical College. Professor Fiaz sir has been kindly recommended by Professor Sridhar sir. And we also have Madam Sumati and Madam Shilpa Madam joining today. And ladies and gentlemen, we have two postgraduates who are presenting. Dr. Sneha is from KM Medical College, kindly contributed by Dr. Shilpa Rao. And we have Dr. Subhash presenting from Government Salem Medical College, kindly contributed by Sumati ma'am. So I warmly welcome the invited faculty. I could see Kanna sir, Jailal sir, Raj Gopal sir. I could see even Dr. Dinakaran sir joining after quite some time. Dr. Hemant sir and Karnakaran sir, Rajiv Sahay sir, and many other faculty who have joined us through the YouTube. We warmly welcome you for this class. Let us have the thyroid case first, then we move on to the breast case. So can I request Dr. Sneha, please introduce yourself, your unit chief and HOD, then start your PowerPoint. Good luck to you, Dr. Sneha.
Yeah, okay. Thank you, sir. Myself is Dr. Sneha More. I'm third-year general surgery resident in the KM Hospital, Mumbai. My guide is Dr. Shilpa Rao and my head of unit is Varsha Kulkarni. Today, shall I start? Hello.
You're good to go, ma'am. Please go ahead.
Okay. Today, I am presenting the next a 65 years lady, resident of Parel, homemaker by occupation, referred from endocrine department in OPD, complaints of swelling in front of a neck for 8 years. History of presenting illness. The patient was asymptomatic 8 years ago when she noticed a swelling in the midline of the neck, insidious in onset, gradually progressive from 3 by 3 centimeter in size to the current size of approximate 8 cross 8 centimeter, and the swelling is not associated with the pain. There is no history of difficulty in swallowing, breathing, and no history of change in voice, no history of blackouts or giddiness. There is no history of watering or redness of eyes, decreased sweating on one side. There is no history suggestive of hyper or hypothyroidism. There is no history of any other swelling in the neck, no history of irritation. No history of irritation of eyes, blurring of vision or dryness of eyes. There is no history of pedal edema, no history of weight loss, breathlessness, cough or bone pain. Past history. There is no history of irradiation to the neck in the childhood. No history of previous surgery to the neck. Patient is a known case of diabetes mellitus and on treatment since 10 years. Personal history. Patient consumes vegetarian diet with the no history of ingestion of goitrogens. Patient has a good appetite with the normal bowel bladder habits, no sleep disturbances, and there is no history of any other drug intake except for the diabetes mellitus and no history of any drug allergies. Patient denies any addictions. Menstrual history. Patient is a postmenopausal with the menarche at the age of 12 years with the regular menstrual cycle for 3 to 4 days every 28 days. There is no history of oligomenorrhea or polymenorrhea. Family history. There is no history of neck swelling in the family or surrounding area. No history of malignancy in the family members. To summarize my history, 65 years lady is a known case of diabetes mellitus with gradually progressive swelling in the midline of the neck for 8 years with no history suggestive of hyper or hypothyroidism and no pressure symptoms. Shall I?
No, just hang on. Sneha, could you go to your first slide, please?
Okay, sir.
Okay, next
Yes,
slide,
sir.
please. You said not associated with pain. Why did you ask for not associated with pain?
Sir, the swelling in front of the neck, like thyroiditis, which is Hashimoto's thyroiditis or Riedel's thyroiditis, are usually associated with the pain. So
you are looking to rule out inflammatory disease, isn't it?
I just wanted to rule out in the initial history. Yes, sir.
Okay, so that is inflammation. What are the other features of inflammation? You didn't ask for that. Did you ask for fever?
No, no, sir. Fever.
Then you should, or any change in color of the swelling.
Okay.
Okay, so that's missing.
Yes, okay.
Okay, you look, your history taking is moving from inflammation to malignancy to benign swelling. You have to go in an order: congenital, inflammatory, traumatic, benign swellings, and then malignant swellings. So history should also go in the same manner. You can't shuffle your history up and down, talking about secondaries one time, then about hyper or hypothyroidism the next line, isn't it?
Okay, sir.
Right.
Okay.
What about watering? Watering from eyes, you've written somewhere. Watering and redness of eyes. Why did you ask for that?
Sir, in the initials, I want to rule out, is there any symptoms of ophthalmology in the patients, like ophthalmopathy? The initial symptoms, which includes the irritation of eyes or blurring of vision, like that's why I wanted to ask.
Are there prominent eyes features of eye signs?
No, sir.
Then we are thinking. I'm thinking you're talking about her honors or something.
Okay, yeah, that is in. Yes, sir. Okay.
Okay, diabetes mellitus cannot be in the past history, right?
Okay.
It is. She's currently on. Did you find out what drug she's taking for?
Sir, metformin. She was on tablet.
That should come out. That should come out in your history.
Okay, sir.
Right. Whether the diabetes is controlled or not, whether she's got any complications. Now, blurring of vision could be because of diabetes also, right? Yes. So you have to find out. Look, you have to treat the patient as a whole. If you have a patient of a thyroid swelling with diabetes, you must rule out. You must also find out whether the diabetes is under control or not by your history.
Okay, sir. By history-wise, it's under control.
Right. So that has not come in your history. You didn't ask about proximal muscle weakness.
Okay.
How did you ask for that in your history?
Sir, is there any difficulty in climbing stairs or from getting up from the squatting position?
Right. So that has to come. Okay. And
Snega, what brought the patient
family
to
history?
your
What did you want to ask about family history? What are the family histories associated with thyroid swellings?
Sir, whether I wanted to rule out, is there any same history of swelling?
No, you answer Professor Jayalal's question first.
Sorry, sir.
What made the patient to come to you? You say there is
swelling
no
in front of the neck.
That is for the 8 years, ma. There is a swelling is for 8 years. The patient is coming to you up to 8 years.
Yes, sir. The patient has been referred from endocrinology department to our department in view of further.
No, why she has come? No, please tell me why she has come to the hospital for? Huh?
Cosmetic purpose, sir.
No,
she wants to get.
After 8 years, she is coming.
After 8 years,
she is coming for the cosmetic reason.
Wants to get
the swelling was increasing in size and she wanted to remove the swelling.
So how long the size is increasing? For the 8 years it is increasing or suddenly that is increasing?
8 years, sir. 8 years.
Slowly it is increasing. Huh?
Yes.
Okay. And you said pain is Hashimoto's thyroiditis. Do you get normally what is the condition which faces painful conditions in the thyroid and why thyroid inflammation is not common?
Sir, in declare events?
No, that is the most painful condition is only recurrent thyroiditis. But why the inflammation is not common in thyroid? We are getting only autoimmune inflammation.
Autoimmune, yes.
Why there is normal infection is not common in thyroid? You don't get the thyroid abscess. You don't get acute thyroiditis very commonly in an adult. Is there any reason for that?
So the
So Sir has asked you
thyroid
very
is
specifically, why do you
encapsulated.
ask pain? Yeah, when well capsulated. What are other reasons?
Encapsulated.
That is one thing, so that bacteria cannot enter. But bacteria normally goes through the bloodstream.
Yes.
So the capsulated thyroid also has the bloodstream will go there. So there are few reasons. One is the presence of iodine, which is an antiseptic. The rich blood supply, which has a good lymphatics, which take away the virus, which will not allow the virus or bacteria to stay there. And it can be only when you have some congenital ARCH deficiency or the pediatric age group, if the patient is having recurrent carcinoma, the patient will have the infection. Otherwise, you will have any. So when you are talking about the symptoms, and as rightly said by Sir, then you must go in an orderly fashion. When you are talking about mechanical compression, you should talk all the mechanical compression together. There is a 6 mechanical compression it can produce. So each organ, and you should be able to explain. You asked about the dysphagia. How do you explain the dysphagia in thyroid? If there is any reason, how will you say, what is the relationship of esophagus to the thyroid?
So the thyroid gland is attached to the trachea by means of Baynes ligament.
No, I'm not asking about the Baynes ligament. Now, what is the relationship of esophagus to thyroid? So it is not immediately posterior. Posterior is trachea, so it can compress on the trachea. We understand. Whether it can compress on the esophagus.
Yes.
So normally from anterior to posterior compression, it has to compress the trachea and then esophagus. But usually what happens in the Hashimoto's, it is a posterolateral compression takes place. So it is without compression on the trachea, you can get a compression on the esophagus. When it is the gland is growing the posterolaterally and posteriorly. Yes. So you must be able to explain when you are talking about all the compressive symptoms, especially when you are talking about the voice change. You are asking for that. And the commonest voice change, what you get in the thyroid, is it due to, what is the commonest cause for voice change in thyroid?
Hoarseness of voice.
What is the commonest reason?
The involvement of recurrent laryngeal nerve.
Definitely not. Involvement of recurrent is a very, very rare phenomenon. The commonest cause should be, you must always talk about hypothyroidism. The patient with the hypothyroidism only will have a laryngeal edema and hoarseness of voice. So your history taking, it is not in an orderly way what we are expecting in a thyroid presentation.
Okay. I think it's Sneha. I think I will just summarize what the sirs were saying. You are right. Right there. Absolutely right. Saying you have
sir, your voice is little breaking.
Whenever, whatever case may be the case, you have to first localize. No, it's okay. Okay. See the first anatomical localization. Here in this case, it is the front of the neck swelling and thyroid is easy. Now that you are localized to thyroid, there are a few conditions you can elicit the history in the history itself. A few conditions of the thyroid, like hyperthyroidism you mentioned. Next is, what about retrosternal extension? Will you get any symptoms in retrosternal extension, thyroid swelling? Okay. What are the symptoms you get in retrosternal extension? Okay. What are the symptoms you elicit in the history?
So there will be difficulty in breathing because of and the facial veins will become prominent, or the flushing.
What position will be the one? What position patient will have more difficulty in breathing?
On raising hands above the head.
No. When the patient is in supine position, isn't it? When the patient is supine position, especially the trachea is soft, you can get easily. You can get the that's a symptom. Also, as you mentioned, the patient is doing something. Patient may intelligent patient, they may notice congestion of the face and etc. All of this. Okay, that's the third condition. The fourth is malignancy. What are the symptoms you elicit to say this is a malignancy in a thyroid swelling?
Rapidly increase in the size of a swelling.
Good. Recent rapid increase in size. Good. Yes.
Hoarseness of voice.
Change in
the voice.
Change in the voice.
Change in voice.
Recent change in voice. You should use the correct term. Recent change in voice. Yes.
Recent change in voice.
Yes. Then. What about then you have to you can classify the symptoms of thyroid malignancy like One is the local symptom of the thyroid gland itself, the reason rapid increase size. Then infiltrate the symptoms, right? Recent change in voice, as somebody Jalal sir was mentioning, the change in the difficulty in breathing, difficulty in swallowing. All this could be due to pressure symptoms. Third will be due to the metastatic symptoms, regional and distant metastatic symptoms. What are the regional metastatic symptoms we expect in a thyroid malignancy?
So in a regional, there will be the presence of like swellings, like palpable lymph nodes or any.
Yeah, lymph nodes and distant metastatic symptoms.
So there might be a bone pain or
bone pain, bone swelling. This brief 2 or 3 questions will quickly tell you whether there's a frank malignancy or not. Okay, and then the last condition I would like to say is thyroiditis. Already mentioned by Jalal sir. Thyroiditis, there have been pain, radiating. Usually in subacute thyroiditis, you get a very mild pain radiating the upper part of the neck with mild fever. This is what you expect. Okay. And one more point I want to elaborate I want to ask this doubt. You said there's no loss of sweating on one half of the face, something like that I saw in your history. What do you mean by that?
Sir, to rule out whether there is a sympathetic trunk in the pressure symptoms, sympathetic trunk compression or not.
Where is the sympathetic trunk?
To Horner's syndrome.
Why do you think in a thyroid swelling you get a sympathetic trunk compression? Where is the sympathetic trunk situated in the neck?
Why the okay.
No, anatomically, where is it located? No, it's far away from the thyroid. Don't mention, the sympathetic trunk compression you expect only in lateral neck swellings. Thyroid is a central neck swelling. Sympathetic trunk is situated posterior to the carotid sheath. Okay, posterior to the carotid sheath. So it is not in the central. Yes, if there is a large lymph nodes in the lateral level 3 or level 2 nodes, which is infiltrating, sometimes you may get the Horner syndrome. Okay. Otherwise, don't mention in a simple thyroid swelling. You don't expect. Okay. And also, if it's a benign swelling, would you expect a nerve lesion, nerve compression?
No,
or
sir.
Infiltration in a benign lesion?
No, sir.
You don't know. You almost never get a nerve. However big the thyroid swelling is, if it's a benign condition, you almost never get a nerve
involvement. Yes, sir.
So here there is no symptoms of malignancy and it's central swelling. It is very unnecessary to say symptoms about Horner syndrome. You will never get. Okay.
Okay, sir.
Okay.
What is the role of sympathetic nerve on a sweating? You said there is no loss of sweat. There is no sweating on that. And why there is no sweating? Is it sympathetic is a secretory cog for the gland or any other reason?
Sir,
it is not a secretory cog.
No. Secretory function.
No, what is the reason why you don't get a sweating in a sympathetic loss function? Because it supplies the erector spinae. That is a muscle which compresses and the sweat is coming out. So the sympathetic supply is for the erector pili, not for the secretory cog for the sweat gland.
Okay, sir.
What are the family history you asked? You asked about family history and surrounding family, fine, good. What are the other family histories probably you asked in the patient with thyroid swelling? Or what are the conditions which can run in the family, thyroid conditions which can run in the family?
Sir, if the patient is from an endemic area, the benign thyroid swelling.
That's fine. That's fine. That is not a family problem. It's an endemic problem. Okay.
Endemic area.
Yeah. What are the other family? I'm asking about the family history. Family, same family. Can it run in thyroid problems? Run in family? Any type of thyroid problem?
Yes, sir. The medullary thyroid carcinoma, which runs.
What are the syndromes associated with medullary thyroid cancer?
MEN2 syndrome associated is most common is the MEN2 syndrome.
There are 2 types of syndrome. It's 2A, 2B.
MEN2A, Sippel syndrome.
2B is not associated with thyroid?
2B is also associated, but MEN2A is more common than the 2B, sir.
Fine. Any other thyroid syndromes associated in family?
Sir,
what about familial medullary carcinoma syndrome? Have you heard of a condition called familial medullary carcinoma syndrome?
Yes, sir. That there is only involvement of the medullary thyroid carcinoma.
That is there. Any other? A lot of syndromes are there. What is Cowden syndrome?
Yes, Cowden syndrome. There is an involvement of breast plus thyroid, usually thyroid carcinoma.
Okay, fine.
Familial adenomatous polyposis. There can be also thyroid involvement. Again, the Werner syndrome also, which is
fine. So there are so many family members.
Yes, sir.
Okay, fine. Right. Okay.
Dr. Sneha, I just want to bring your attention. What is the age of your patient?
65 years.
65. And what is the duration of the thyroid swelling?
8 years.
8 years. So what is the most common, if at all, toxicity you expect in your patient? If at all.
Hyperthyroidism.
No, hyperthyroidism, correct. What is the toxicity referred to? Which system? Which system?
Cardiac.
Cardiac. So what is one question you should have asked?
Palpitation or tremor.
So don't get, that is what I'm trying to tell. So instead of trying to mentioning dryness of the eyes, conjunctivitis, redness, irritation, all unnecessary, unwanted sweating on the right side of the face, all those are not required. After you talk about the local compression, long-standing goiter, so some dysphagia you have mentioned, some difficulty in breathing, or it also adds to retrosternal. Plus, one straightforward question: do you have any palpitation, or that's if with breathing difficulty? So that would have been more than enough. Then you straight away say no history suggestive of any toxic features in the form. So that is one. So don't have to get to trouble in the examination. Unnecessary things are not required. That's what I would like to mention at this time. Okay, please go ahead.
Shall I proceed with the examination part?
Okay.
Yeah, go ahead.
General examination. Patient is conscious, cooperative, and well-oriented in time, place, person. Patient looks comfortable at rest. Patient is afebrile with the pulse 88 beats per minute in right radial artery with regular rhythm, normal volume and character. Blood pressure is 120 by 70 millimeters of mercury in right brachial artery in sitting position. Respiratory rate is 12 cycles per minute, and the patient's BMI is 24.6 gram per meter square with the weight of 64 kg and the height of 162 centimeters. There is no pallor, icterus, clubbing, cyanosis, neuropathy, and the pedal edema. There is no evidence of eye signs, no evidence of hand tremors, tongue fasciculations, no alopecia, and the nails of the patient are normal. Proceeding to the local examination, the patient is examined after informed consent in the well-light room with adequate exposure in sitting position. There are the photos of the swelling. On inspection, there is a globular swelling of size 8 × 8 centimeter is seen in the anterior aspect of the neck in the midline, extending from upper border of thyroid cartilage 1 centimeter above the suprasternal notch, laterally from medial border of left sternocleidomastoid, medial border of right sternocleidomastoid with well-defined margins and nodular surface. The lower border of the swelling is visible.
Just hold on. Just hold on. We can't hear you. Dr. Meenakshi Sundaram. Hello. Could you please mute yourself? Dr. Meenakshi.
Sir, 1 second, sir. 1 second. Sir, I think we have sorted out, sir. Very sorry for that.
Yeah, sir. Yeah, it's okay now, sir.
Shall I start? The lower border of the swelling is visible. Skin over the swelling is normal. There are no pulsations seen over the swelling. Swelling moves with deglutination but does not move with the protrusion of the trunk. Trachea appears in the midline. On palpation, there is no local rise of temperature or tenderness. The inspector.
One moment. Professor Faiz, sir, you can unmute yourself and ask questions. I could see you posting questions in the group.
Yes, sir.
Professor Faiz Hussain, sir.
Yeah, sir. I can hear
sir,
you, sir.
Please ask questions directly.
Sure, sir.
For students, sir, you are welcome to ask questions openly in the forum.
No problem, sir. I'll ask. Not a problem.
Thank you. Dr. Sneha, go ahead. Sorry for the interruption.
No problem. Please go ahead.
Inspectory findings are confirmed. A well-defined globular swelling of size 8 by 8 centimeter is palpated over the anterior aspect of the neck in the midline, extending superiorly from the upper border of the thyroid cartilage to 1 centimeter above the suprasternal notch inferiorly, and laterally from the medial border of left sternocleidomastoid to the behind the medial border of the right sternocleidomastoid. Right and left lateral borders are well palpated on Lahey's method. The swelling was firm in consistency with the nodular surface. Trachea is central in position. The bilateral carotid artery pulsations were palpable at normal position. Lymph nodes not palpable. On percussion, there is a resonant note over the manubrium. On auscultation, there is no bruit heard over the swelling. On systemic examination, on central nervous system, there is no hand tremors or tongue fasciculation. Deep tendon reflexes are normal. No proximal myopathy. Cardiovascular system, there is S1, S2 heard without any murmur. There is no tachycardia or arrhythmia. Respiratory system, bilateral air entry is equal. Per abdomen, there is soft non-tender. To summarize my case, it's a 65 years lady, known case of diabetes mellitus with gradually progressive swelling in the midline for 8 years with no history suggestive of hyper or hypothyroidism or no pressure symptoms. With the examination findings suggestive of well-defined globular 8 by 8 centimeter swelling in the midline, form in consistency with the nodular surface that moves with deglutination, is probably a case of multinodular goiter.
Dr. Sneha, do you have a picture of this patient?
Yes, sir.
Show that again. Yeah, just, yeah.
The picture is in supine position, sir.
Yeah, but can you show the, do you have any picture in the neck extended position?
No, sir. No. I have this only.
Why you want to examine this thyroid patient in the extended position? Any advantage you can get?
That makes the swelling more prominent. You can see whether this area is diffuse.
Why does it become more prominent if you extend the neck? Yes, your answer is correct. But think if you extend, what will happen? There is some amount of cervical lordosis. Okay, it pushes it to some extent, and that is first point which I would like to mention. Second thing is, I personally feel one palpation, the first thing should come out from your side is what exactly is palpable, instead of trying to say no local raise of temperature and tenderness. The reason is this is thyroid swelling. You understand? You already made it on inspection. It moves with the deglutination is wrong. The deglutition. Okay.
Yes, sir.
2-3 times you said deglutination. So I think you correct yourself.
So
once you know that it moves with the deglutation, then there's no point in, so you can straight away tell thyroid is palpable. You should have clearly mentioned what is palpable. Right lobe palpable, left lobe palpable, isthmus palpable, because you said globular and then you said nodular. And the two pictures you see carefully for us looks like both lobes are enlarged. Especially this the one, when the both lobes are enlarged, how can it become globular in shape? Correct? So few things you need to understand always. Put a sketch in your case sheet and see whether it fits in with your size, shape, surface, borders, consistency. When a swelling occupies both sides of the trachea, there is no point in mentioning movement on protrusion of that time. Is it clear?
Okay.
It is only for a solitary nodule very close to the midline, may mimic a thyroglossal system. When you have both sides goiter like this, it is not required. Few things are, small corrections you need to do. Right? Okay, these are few. Please take over.
Yeah, how did you find that the trachea is central in position in this patient?
Sir, it is on palpation, sir. It was not on the inspection findings, but on palpating, keeping the two fingers on the sternum and one palpating with the one finger on either side of the trachea.
No, I'm asking especially about this patient where there is a bilobar enlargement is there, and this is almost going up to the suprasternal notch.
Yes, sir. But
you able to appreciate that?
Yes, sir. We were able to appreciate the trachea on palpation.
I think it's very difficult to palpate the trachea in this patient. You have to use auscultation. It's a better method of finding whether the trachea is central or not, rather than palpation. with such a large swelling, it's quite impossible.
Staying with the trachea, Sneha, can I ask you, okay, did you do a coccus test and do you think it's important in this case? The 8-year-long standing swelling of the thyroid and pretty large in size, as we can see. As correctly mentioned, it's not a globular swelling, it's a nodular swelling. You should present it as a nodular swelling involving both lobes as well as the isthmus, as by this picture which you have shown. Do you think the coccus test, have you heard of a coccus test, and what is the significance? What is the significance in this particular case?
Coccus test is on compressing the swelling from one side to the opposite side. It will compress the trachea and will produce a stridor.
In all cases,
in large
when will you get it?
No, when there is an enlargement of lateral lobes rather than.
Whenever in all thyroid cases you get a coccus test positive, that means all thyroid swelling we pressed from both sides, you get the trachea compressed, you and get stridor.
No.
You don't get it. You don't get it normally. So what does it indicate? Suppose you press from both sides or one lateral side to medial, lateral to medially, you get the difficulty in breathing and stridor sound. Okay. So what does it indicate? What does it indicate?
Sir, on involvement of the isthmus.
No.
If the isthmus is compressing.
No, it's a very,
what is the reason for?
Yes, what is the reason? It's a very important test for anesthetists, not only for surgeons, also for anesthetists. Again, see, when you get the compression of the thyroid, when you compress the thyroid and you get the stridor in a patient with a large thyroid swelling, it is a very ominous sign for the anesthetist. Okay, because that shows the tracheal rings are collapsible. Okay, they are very, very soft. They become soft. What do you call this condition?
Tracheomalacia.
Okay, so probably that, and it's a trachea is soft and collapsible. So after removal of the thyroid, it can produce post-operative problems. Okay, why does it produce? Why it doesn't produce stridor or collapse of the tracheal ring when this large thyroid swelling is sitting on the trachea? But on removal, actually, the patient may get stridor. What is the reason? Why he doesn't get a stridor when such a large swelling is sitting on the trachea all this time? But on removal, he may get a stridor. What is the reason? It is usually on removal after thyroid surgery. Okay, thyroidectomy, the patient go in for collapse. That is the reason is when the large thyroid is sitting on the trachea, due to the adhesions between the pretracheal fascia and the thyroid itself may support the tracheal ring, which is very soft. But on removal of the trachea, thyroid gland, the support is gone and the tracheal rings will collapse. Okay, so it's a very important test you should have done, a coccus test, right? Another point.
Why do you want the trachea to be kept open always? Esophagus is not kept open. It is only when you are eating, it is esophagus is getting open. Why do you want the trachea to kept open? What is the shape of the trachea?
So it's a tubular, tubular structure.
It's a tubular, totally tubular. What is the shape of the trachea? It is a D-shaped. It is only the anteriorly you get the cartilage and the posteriorly you have the muscle. So why do you want the trachea to be kept open? What is the tidal volume? Do you know what is dead space volume?
Sorry, sir?
Dead space volume in respiration. And what is the significance of the dead space volume?
Okay, the trachea and the bronchi make the dead space, which will there will not be active exchange of the air oxygen level.
How many times your exchange is taking place in the lung?
Sorry, sir.
How many times exchange will take place? Is it 16 times or normally 70 to 80 times?
70 to 80
it is
times.
depending upon, but you are only breathing the 16 to 18 times. So that the volume of the air which is kept in the dead space is mandatorily required for the continuous exchange of the air to take place in the alveoli. So that is why we always want the trachea to kept open. Not like only when eating when the trachea, esophagus can be kept open. Similarly, when you breathe, the trachea can be open. So the significance of the Koch's test. If the trachea cannot be kept open, then the patient will be definitely going for the problem, and the dead space volume of the air will not be available for the gaseous exchange to take place. So that is the priority concern. So when you see the Koch's test is positive, what is the pre-concern you will get from the patient? The patient may need a tracheostomy. So, and you must get ready for the tracheostomy. In the post-operative period, if the trachea is not opening up and the patient is having a collapsed trachea, you must go for the tracheostomy. So that is one of the very, very specific investigation test you do to assess or predict whether this patient will need a tracheostomy or not in the post-operative period.
Another test she mentioned is the lower border is palpable. That is also again a very important test in this case, because the lower border is not palpable. That means what does it indicate? The lower, that's again a big issue. The large thyroid retrosternal extension, the lower border is palpable. That is okay, sorted out. You mentioned there is no bruit on the thyroid gland. I think I heard you. I think
yes,
what is bruit and where usually you check for bruit?
It is checked over the superior pole of the thyroid, and it is due to the turbulent blood flow.
You should say this. You said heard over sometimes in very highly toxic thyroid you may get glandular bruit, but usually it is why you check on the superior thyroid artery.
The superior thyroid pedicle is superficial as compared to the inferior thyroid.
Yeah, it's more superficial and more consistent in its branching, isn't it? The inferior thyroid artery also you may get the bruit, but it's posterior and branching pattern is very inconsistent. So usually you check it in the superior thyroid pole, right? Superior pole of the gland.
Superficial.
What is your finding on auscultation?
She said no bruit, no bruit.
No bruit, sir.
No bruit. You forget about bruit. What you heard on auscultation? Did you hear anything?
So the nothing. Air entry.
Sagai sir has given a clue when you were stated about the tracheal compression.
Air entry.
Tracheal pulsation. So don't only say what you are not palpated, what you are not heard, and please say what you have heard.
The air entry.
Will you able to hear so definitely when you are auscultating, you are also not only auscultating only for the bruit. So very, very rare, unless you are thinking in terms of the Graves' disease, you don't get a bruit yet. That is not the reason why we are asking you to go for auscultation. So that is auscultation will be able to tell you that where exactly the trachea you will be able to identify. If the trachea is shifted, when a large tumor like this, it is not the 3-finger test cannot detect you whether the trachea is shifted because you are not able to palpate. Where is the trachea you will palpate? Where is the trachea starts?
From the C6 level, the larynx.
So what is corresponds to C6 level corresponds to what? What are the anatomical events taking place at C6?
So just below the cricoid cartilage, it's just the C6 level and the.
It is at the level of cricoid cartilage. Esophagus, pharynx become esophagus, larynx become trachea, and common carotid artery bifurcation. So that is a very significant area where you are going to see the trachea. So that means cricoid is at the lower end. It's a very lower part. Only 3 to 4 fingers rings of the trachea only you will be able to feel. In a 3-finger test, it is very difficult to identify a trachea and do that in the large swelling like this. So only way you can do is an auscultation. Here in auscultation, you should have mentioned about whether the trachea is in the midline or whether the trachea you are the breath sense how you are giving. That is more significant, and we don't expect this case to be a Graves' disease and to get an auscultation in this case.
Yes.
When will you get bruit? Okay, let me ask one more last question on the auscultation again. When will you get a bruit on a thyroid gland? And what are the reasons for getting bruit?
So in case of the turbulent blood flow over the in the superior pole of the superior vessels.
Due to what?
Because of the increased sympathetic activity leading to.
No, it has nothing to do with sympathetics and bruit. See, bruit can be due to actually, we are right, it's due to turbulence of flow. The turbulence can be produced due to either by hyperdynamic circulation or by narrowing of the vessel, isn't it? So normal flow through a narrowed vessel or abnormally high flow through a normal vessel. So what is the common cause for bruit in a thyroid gland? It is in
hyperthyroidism.
Hyperthyroidism, what happens? What happens? So the
hyperdynamic blood circulation.
Hyperdynamic blood circulation. Rarely, maybe malignancy compressing. That's very, very rare in thyroid gland. Usually, bruit is heard in hyperthyroidism. What is the difference between hyperthyroidism and thyrotoxicosis? Is there both are same, or is there any technical difference?
So these two are different. Hyperthyroidism is just an increased synthesis and secretion of thyroid hormones from the thyroid gland.
Yes, good.
And thyrotoxicosis is a clinical syndrome because of the circulating raised levels of thyroid hormones, irrespective of the source.
Yes, I think you are right because the hyperthyroidism is hypersecretion of the thyroid glands, thyroid hormones, and thyrotoxicosis is that it is due to the abnormally high blood circulating thyroid hormones, not necessarily due to increased secretion from the thyroid gland. So, can you give one or two examples of thyrotoxicosis?
Sir, the factitious disorder in which the yes, there is a external supplementation of thyroxine in New York.
Yes, agree. Anything else?
Excess of iodine intake, like iodine intake in the form of drugs which are taken.
No.
Like.
Okay, that produces thyrotoxicosis, hyperthyroidism, isn't it? That increases secretion. That is not thyroid.
And the struma overa, if there is a presence of thyroid tissue in the ovary.
No. What about thyroiditis, transient phase of increased secretion of thyroid gland? Is it due to hypersecretion or due to increased release of the hormones into the circulation?
Hashimoto's thyroiditis, which
increased the release. Transient phase of hyperthyroidism. That is not hyperthyroidism. That is thyrotoxicosis because there is production. It is due to follicular damage.
Lymphocytic infiltration of the thyroid.
What is hamburger thyrotoxicosis? Have you heard of that?
Sorry, sir?
Hamburger thyrotoxicosis.
Hamburgers, no, sir, I don't know. No, sir, I don't.
It is actually a fictitious type of thyrotoxicosis because there are some people make burgers with the gullet of the sheep, the meat from the neck part of the sheep that may contain the thyroid extracts and produce the thyrotoxin. So these are the three main examples of thyrotoxicosis: thyroiditis, the fictitious thyrotoxicosis, and the hamburger thyrotoxicosis. Okay, they are not hyperthyroidism but thyrotoxicosis.
Trega, suppose you get a patient with a T3, T4 increased level. How do you say that it is a transient hyperthyroidism or a hyperthyroidism due to Graves' disease?
Sir, measuring the levels of TSH?
TSH may be very, even that it is only in response to the negative feedback system. When the T3, T4 is increased, the TSH will be low.
Yes.
A patient comes to you, he shows the T3 level, T3, T4 is high. And now, see, remember, 25% of hyperthyroidism is transient hyperthyroidism. Autoimmune thyroiditis is increasing. So you need to differentiate because the treatment is entirely different. So what are the ways you can differentiate transient hyperthyroidism from the regular hyperthyroidism? Or thyroid, you get in a Graves' disease. Any test you can do?
Antibody, IgG levels, antibody levels.
What antibodies you will test?
Sir, the TSH receptor antibody or anti-TPO antibodies like thyroid peroxidase.
TSH receptor antibodies will be increased in Graves' disease. What is the antibody will increase in the thyroiditis?
Sir, thyroid peroxidase antibody.
Very good. Then what any other test? Suppose you have a facility to do the thyroid uptake
Thyroglobulin. The thyroid scan.
Thyroid uptake scan. Also, what is the result in transient hyperthyroidism? What will be the result in the thyroid uptake scan, and what will be the result in the Graves' disease?
Sir, in a Graves' disease, there will be the diffused intake of the thyroid, which will suggest there is
decrease
the
intake. Graves' disease, there will be decrease intake.
Diffuse, sir.
You call the diffuse intake or vivid intake? Okay, increase intake. And when will you say what percentage of increase intake is called vivid intake? So 16 to 45. If there is a more than 45% intake, you take it as a vivid intake. There is uptake is high. So that is for a Graves' disease. What will be the intake in a thyroiditis?
This will be reduced in case of thyroiditis. It will be
reduced or almost nil, because here it is a follicular rupture. There is no follicles to store them. So there is a two tests which we do. One is the antibody test, right? Thyroglobulin receptor antibody or a peroxidase antibody. Equally, you do the uptake scan. So both will be only able to tell you, because nowadays it is becoming very important because we are getting a lot of cases of autoimmune thyroiditis, where it is a transient hyperthyroidism. And if you put the patient on hyperthyroidism, patient will be easily go to the triphasic disease. So you need to be extremely cautious in taking a decision whether the patient needs. Okay.
You casually mentioned about lymph nodes not palpable. What do you mean by which are the nodes you palpated? Or you should, I think, don't you think you should be a little more specific in the nodes? Lymph nodes not palpable. Just one sentence you mentioned. What are the nodes you usually examine?
Sir, I want to rule out whether there are level 6, 7 as well as 3, 4 and the posterior triangle.
6, 7. That you can palpate level 6, 7 and all?
No, sir. No, sir.
Can you palpate level 6 and 7?
Can you palpate level 6 and 7?
It is very difficult.
No.
So what is the
very difficult to palpate 6 and 7?
Normal method?
3, 4 we can do.
Normal method of spread of thyroid malignancy. What is the first group of nodes usually involved in thyroid?
Level 6 is the first
Level
involved.
6, from there it goes to
7.
7. Oh, yes, maybe more, not 7. But what about lateral nodes?
Then 3, 4. Then 3, 4.
Next is 3 and then 4. And these are the two. The one group of nodes which is in the neck, which is usually not involved in the thyroid malignancy, which is that group of nodes? Level
2.
Level 1. Level 2 may be involved. Level 1 is because level 2 may be involved, and the level 1 is usually not involved, and usually it is not part of the lymph node dissection in the level thyroid malignancies. Okay. So is there any type of malignancy, any area of the thyroid where you get malignancy, where you get directly level 3 node can be involved without going to level 6?
Anaplastic thyroid carcinoma?
No. Any particular anatomical location for the thyroid?
Sorry?
Any anatomical location where you get thyroid, usually the thyroid malignancy go to level 6, from there 3, 4 like that, isn't it? So which anatomical location of the thyroid malignancy where you get directly level 3 or 2 nodes can be involved without going into level 6?
Where do you do auscultation?
Superior pole. If there is an involvement of superior pole as a lateral
bar of the lateral lobe, superior area of the lateral lobes, you can go directly to level 3 without going to level 6. So you should mention which are the nodes you're palpating. There are no nodes palpable. Lateral, at least deep cervical nodes are not palpable on both sides, not only one side. It can go to other side also, isn't it? So lymph nodes not palpable is a vague statement. You have to be a little more specific on that.
Okay.
Now, I was a little worried about when you said it is a globular swelling, but a multinodal goiter. We normally don't get a globular swelling in a multinodal goiter.
Okay.
So are you very sure that it was only a globular swelling?
No, sir, rather I would like to say it is a multinodular swelling.
No. When you are describing the swelling, you said 8 into 8 centimeters is a globular swelling. That means the swelling is in the isthmus, or it is on the 2 lobes only there.
Can you show the diagnosis, that last sentence diagnosis? Okay, do you think this diagnosis is complete? Is it enough? You want to add a little more to the diagnosis?
Is it probably a case of non-toxic multinodular goiter without any pressure symptoms when in a euthyroid state?
Yes, you need to add a little more, isn't it? Multinodular goiter and euthyroid state. And probably can add without any complications. That's what we can. So then the next question will be what are the complications you can expect in a multinodular?
Mega, though it is undergraduate questions we ask, and how do you say it is moves with the deglutition?
So
can you explain why it is moves with deglutition?
The lateral lobes of the thyroid are attached to the thyroid cartilage, and also by means of the pretracheal fascia, which is
there is no way lateral lobe is attached to thyroid cartilage.
And it is attached with the trachea by Berry's ligament, also pretracheal fascia with the Berry's ligament.
Where do you get the Berry's ligament? From where you get the Berry's ligament?
The pretracheal.
So where do you get what is pretracheal fascia? Where do you get the pretracheal fascia? No, where do you get the pretracheal fascia is from where? So this question is one of the very common questions we normally ask for the postgraduate, and where we do not ask a telegraphic answer. We want a very specific answer. You understand how the pretracheal fascia is formed and how it is developing, and what are the layers of the deep cervical fascia. So you must know what is the investing layer of deep cervical fascia, what is the pretracheal fascia, and how it is formed the Berry's ligament, I even sometimes ask the postgraduate how many Berry's ligament. Many times the postgraduate started saying that's a one Berry's ligament. Please remember, it is a Berry's ligament. It's on the either side. It is not on the midline. It is on attached to the. What is the relationship of Berry's ligament? Where is it attached?
So at the level of C2, C3 tracheal cartilages, it is in the at the level of isthmus.
C2, C3, no.
Don't say vertebra.
No, there's no notion of the isthmus.
Sorry,
Far behind.
No, what is the cartilage? It is not the tracheal rings.
Just below the cricoid cartilage.
No, if it is attached to tracheal rings, it has nothing to do with the
movement,
which is
deglutition. See, trachea has nothing to do with deglutition.
So what is it is attached to the cricoid cartilage, then why it moves on deglutition?
So the inferior thyropharyngeus and cricopharyngeus muscles are attached to the thyroid and cricoid cartilages, and the thyroid is indirectly attached to the thyroid cartilage. That's
no, please try to postgraduate. You need to explain it properly. You are right when you say thyropharyngeus and cricopharyngeus in inferior constrictor. So when the pharynx is contracting or when the patient is swallowing, the pharynx contracts, it pulls up the cricoid. So whatever stretches, it is attached to that. So you must start saying that's the deep cervical fascia, investing layer, switch to enclose the thyroid to form pretracheal fascia, posterior layer condense. It is attached to the cricoid. Cricoid is attached to the inferior constrictor. So this is a sequence of events. Don't in a postgraduate, we don't expect you to talk in a telegraphy language, one few language, Berry's ligament, and then thyroid moves. So this is a concept which you must always know. I think Ajay Kandasar is here. He is very particular in saying it is this. You can't say it is a it's a moves up. Whether it is what is how it comes down. Also, he used to ask the question.
Okay.
So deglutition is only the where we are interested in talking about the moving up. We are not talking about the phenomena of the moving down. Okay, go ahead.
Okay, I think you'll go to the next investigations, isn't it? Now I think.
Sneha, I just wanted to know that what is the position of the sternocleidomastoid in this patient? Could you go that to the photograph? Just go to the photograph and see what is happening to the sternocleidomastoids.
Show the photograph, yeah.
Yes, sir.
Tell what is happening to the sternocleidomastoids.
Sir, it has become prominent on the right side without the right now because of the lower border. It is completely visible, the medial border and the lateral border.
Yeah. So what does that mean?
The swelling is going behind the sternocleidomastoid.
You know what is that sign known as? Prominent sternocleidomastoid is a sign of?
No, sir. No, sir.
What is Tinel's sign?
Okay.
Trias sign, yeah. Not the Tinel's, the trias sign, yeah. Okay, there's a prominent sternocleidomastoid because of the underlying deviation of the trachea. Okay. So that can say that there is a deviation of the trachea on the right side here. Okay.
Okay.
So rather than palpation, so you can know here by either by the inspection or by the auscultation. Okay. Yeah.
Okay.
Go ahead. Yeah.
So you have to modify diagnostic multinodular goiter, euthyroid without any complications.
Without any complications.
What are the complications you can expect in the multinodular goiter?
Sir, it can be. There might be a.
No complication. You are excluding certain complications, isn't it? What are the clinical complications excluded?
First, there are no pressure symptoms. There is no compressive symptoms.
No compression, yes.
Symptoms.
No retrosternal extension.
There is no retrosternal extension of the
clinical evidence
swelling.
of malignancy, isn't it?
Yes, sir.
No evidence of toxicity. So already you already mentioned. So what type of malignancy you usually get in multinodular goiter?
Follicular thyroid carcinoma.
How many percentage of multinodular goiter get follicular carcinoma?
Sir, very less, like the 7 to 8%.
Yeah, 5 might be 5.
No.
Less than that. Okay, very good. Okay, I think now I feel
any other carcinoma MNC can produce? Not carcinoma. Any other malignancy it can produce? MNC is also more prone for lymphoma.
Lymphoma.
Especially when you have a Hashimoto. Suppose it is a Hashimoto's thyroid is producing MNC. So what type of carcinoma you get?
Thyroid lymphoma.
No. What is the most common carcinoma arising from Hashimoto's thyroiditis? It is again papillary carcinoma. It's not a lymphoma. So it is a papillary carcinoma. The second commonest possibility you get is a lymphoma you can get.
Okay.
So when Sir has asked the question of the complication, you must talk about malignancy. You should talk about the secondary thyrotoxicosis. You should talk about all the complications which is persistent to the MNC cancer.
There are no complications, but the questions will come. What are the complications you expect? You should be able to answer that. Okay.
Yes, sir. Yes, sir.
Okay. If there are no more questions to the clinical examination, we'll proceed with the investigations further management. Okay. What will you do for this patient?
Sir, first starting with the thyroid function test and biochemical test for the thyroid function test, and then USG NAC, followed by SOS FNC, USG guided FNC of the swelling.
No.
Please go in a sequential order. What is the first test you will do, and what do
you go in a sequential order, and also what you expect in the test, and what will suppose the result is this, what will you do? What suppose the result is A, B, what will you do? Like that you proceed. Not like you order some test and you go ahead with another test. Not like that. Okay.
Okay, sir. First, I would like to do the thyroid function test, measuring the serum T3, T4, and the TSH level. If it is, I would like to.
Why do you want to do the serum thyroid function test first?
So just to confirm the euthyroid status of the patient, there are no clinical symptoms of hyperthyroidism, but to confirm it with the thyroid.
Whether your treatment and your modalities of investigation is going to change by knowing whether it is a euthyroid or.
No, sir.
No, in a diagnosis, the first is organ of involvement, and what is the organ is involved, and how much is involved, and that is going to be the major part. So. It is now it has become a routine. Always you try to do with the ultrasound. Yes. So confirm that you are finding that it is a thyroid. That it can be, there are a lot of differential diagnoses for this. So you confirm that is ultrasound. Then you can go for the thyroid function test or whatever the way you want to go ahead with that.
Okay.
So when you are doing ultrasound, what is thyroid?
Sorry, sir. Thyroid.
Thyroid.
Thyroid imaging and reporting and data system.
What are the components you look in that?
Sorry, sir.
What are the factors you look into that?
No, you do an ultrasound of the what are the things you look for? That's a question.
First, looking at the enlargement of the thyroid gland, the solid cystic component, again the nodularity, the number of nodules, and again the vascularity of the gland and the lymph node status of the neck.
Features suggest a malignancy in a thyroid nodule. Thyroid could be malignancy.
Sir, the increased vascularity and the calcification status.
Again, you need to be very specific in these two. What type of increased vascularity? Increased central vascularity in a nodule, and what type of calcification? It's all vague statements.
Microcalcification. Yes. Microcalcification for the malignancy.
Microcalcification. Microcalcification is not significant. It's not related to malignancy. Okay. What are the other features?
Again, looking after for that lymphadenopathy.
Okay, cervical node. Anything related to the node itself? I mean, nodule itself, thyroid nodule itself. They could be taller than wider. The nodule size will be in a uniform manner rather than the wider manner. Taller than wider nodule.
Wider than taller will indicate the benign.
Yes.
Wider than taller will indicate the benign.
So you should know the features of the thyroid and what are the characteristic features we are looking for. And you said looking for the node. What is the importance of ultrasound looking for the node? And is all the nodes the ultrasound can be located?
Yes, sir,
very difficult by, or we can do the cervical lymph node, but it is very difficult for the pretracheal and paratracheal node. Level 6 node identification with an ultrasound is a very difficult. That is the only role when we are going for a CT scan. So CT scan only will be pick up the more of the central neck node. The ultrasound will not be able to pick up. I mean, when we say it is a normally, a good ultrasonologist can also pick up. But normally, picking up a central neck node is a very difficult doing in an ultrasonogram. It is that is the reason why we normally go for a CT scan of the neck, where they will be able to detect the central.
Okay.
So you should know the findings of the tumor, whether the cyst or the solid, which can be told whether it can be, you can predict whether it can be malignant or cystic by the thyroid scoring.
Okay.
You did an ultrasound. What will you do next? You did a thyroid function test, and thyroid function. Suppose thyroid function test is hyperthyroid. If you're getting a hyperthyroid, what will you do? Suppose it's getting a hypothyroid or euthyroid. Is there any difference in the management then for that? After ultrasound, what are you going to do? You did a thyroid function test and ultrasound. Both you did. What are you going to do next?
USG guided FNAC of the swelling.
So all thyroid nodules, you go ahead and do FNAC, or is there any protocol based on your ultrasound findings?
So your voice is breaking.
No, you do FNAC in all. I think somebody's mic is on. I think Dr. Shekhar. Yeah, thank you. So will you do FNAC in all thyroid nodules, or you will be selective?
Sir, all thyroid nodules to have the diagnosis
of the size, irrespective of the character of the nodule. Then why are you doing an FNAC? Sorry, say ultrasound. Why are you doing an ultrasound? Next question: any thyroid nodule? Can you just wait and watch before doing an FNAC, or we can just follow up these patients without doing an FNAC?
Yes, sir. If there are no features suggestive of malignancy, the benign swelling points towards the benign lesion, then we can wait with the follow-up of the patient.
The answer is
how about thyrotoxicosis? Can you do FNAC?
I think Snega, you can close down your presentation and you can go for the discussion. I think presentation is.
Yeah, you can switch on your mic also. Yeah, as sir mentioned, thyrotoxico. That's why you do thyroid function test in the beginning. If it's a thyrotoxic patient, you don't do an FNAC. You straight away manage the thyrotoxicosis or hyperthyroidism, whatever. If it's a euthyroid or hypothyroidism, you go ahead and do an ultrasound. An ultrasound will guide you whether you should do an FNAC straight away or not. Okay. According to ultrasound, Thyroid's classification is there. Malignancy features we discussed, depending on the size and the character. If its size is more than 2 or 1.5 centimeter, more than 2 centimeter, and hypoechoic, you call it a high risk patients. Intermediate risk is 1.5 centimeter round and hyperechoic, isoechoic or hyperechoic lesion with some features of malignancy called intermediate risk. Low risk nodules are purely cystic, no solid components, less than 1 centimeter. So it is in this group you probably can wait before doing a straight away FNAC. Okay, less than 1 centimeter, purely cystic, no solid components, and no features of malignancy. Okay, so you can pick up these small nodules, but you no need to do straight away FNAC. You can wait for that. Okay, so that's the only group where we are not completely saying no to FNAC. We are keeping under close watch. We'll keep this patient under watch. Later, once we will keeping upon clinically as well as ultrasound, we may examine them once in a year or something. Any change you can do FNAC like that. Okay, because very less chance of malignancy. Also in toxic nodules, you do the FNAC, right? Other groups you do an FNAC. So ultrasound can help you in picking up the correct nodule for FNAC with the nodules with the features of malignancy. If suppose more than one nodule is showing some features of malignancy, what will you do? From where you pick up there to do the FNAC? Which nodule will you do FNAC?
So the solid, which is more in the solid in the consistency.
No, I'm telling you,
necrotic.
More than one nodule is showing some features of malignancy, or both are solid nodules.
Sorry, sir, I didn't get it.
No, there are 2 or 3 nodules. All the 3 nodules are having some features of malignancy in ultrasound. All are solid nodules. From which nodule you will take the FNAC, select to do the FNAC.
The one with the minimal vascularity and
No, actually the answer is very thing. Either you can do from the largest nodule, okay, or you can do from multiple nodules. What is no problem? You can do FNAC from all the nodules, or you can select the largest nodule which is having features. Okay, so there's no problem in doing from more than one nodule also. Okay.
Okay.
No. After FNAC, what will you do?
Sir, first, if there are no, the patient is in euthyroid state, and I would like to give an option of surgery for the patient. If the patient is willing for it, I would like to go with the surgery.
So you will do straight away do surgery after FNAC in all patients, or you don't look at the Bethesda classification and all?
Yes, sir. Looking at the Bethesda classification of FNAC, if the swelling is benign, I would like to give an option of the follow-up for the patient. But if it is Bethesda 3, which is suggestive of the follicular atypia, where I would like to give the option of the surgery followed by for the Bethesda 4 and 5, where there is a management is definitive surgery.
Yes. Maybe 1 and 2, they are purely benign lesion. There is an option of non-operative management. Okay, can wait. 3 is, as you mentioned, it's in between, follicular lesion of undetermined significance. Okay, maybe you are a little dicey. 4, 5, and 6, I think you better surgical option. You have to go for surgically. That is the importance of doing an FNAC and classifying according to the Bethesda classification. Okay. Right. Suppose the FNAC's report is follicular neoplasm, Bethesda 4. What will be your line of management?
Sir, if it is, I would like to, if it is involving the single lobe of the thyroid, I would like to go with the hemithyroidectomy with the frozen section. If it is
we are talking about this patient. We are talking about this patient, your patient. You will go for a hemithyroidectomy in this patient.
No, sir. Total thyroidectomy. If we consider this patient, the total thyroidectomy for the patient.
Even if suppose FNAC is multinodular goiter, nodular colloid goiter, what will be your management?
So total.
Yes, this patient definitely has to go for total thyroidectomy. Why? What is the reason? Why you want to, even if it's benign, why do you want to do a total thyroidectomy in this patient?
Sir, the swelling is increasing in size, and just to prevent the compressive symptoms also. And sir, today's there is no more of the total thyroidectomy is preferred over the any other near total or the subtotal thyroidectomy.
No, what is the reason in this particular? There's a reason. No, this is what is your diagnosis? Multinodular goiter, isn't it?
Multinodular goiter.
Involving both lobes and isthmus, isn't it? So
yes, sir.
You can't retain any part of the thyroid gland which is pathological, isn't it? Both lobes are involved and isthmus are also involved. So total thyroidectomy, there's no doubt. But okay, even if it's benign, since today's class is about benign, so we don't go into the malignancy side, I think. Okay. So we'll do a total thyroidectomy, isn't it? Even if it's thyroid. All right. What are the problems in doing total thyroidectomy?
Sir, there might be an injury to the nerves, or the post-thyroidectomy, there will be a hypoparathyroidism and the hypothyroidism.
Hypoparathyroid. How will you prevent injury to parathyroid gland?
So the recurrent laryngeal, looking at the being more careful at the Baries ligament and the inferior pole of the thyroid.
No, parathyroid gland. I said parathyroid gland. How will you prevent the hypoparathyroid? So you said hypoparathyroid, no? What is the method to prevent the injury to parathyroid?
Intraoply, na, sir?
Yes, yes.
Sir, in the there might be a recent advance which is use the nerve stimulation technique, which will detect the nerve.
No, I'm talking about parathyroid gland. You are talking about the recurrent laryngeal nerve. Okay. That is the problem.
Sir, the parathyroid ke liye, sir.
No, what is the main reason for hypoparathyroidism after total thyroidectomy?
Vascular insult to the parathyroid gland.
Exactly, vascular injury, isn't it? You may have seemingly preserved one parathyroid gland, but you may have injured vascularity. So that's vascularity of parathyroid.
Ligating the capsular branches of the inferior thyroid artery rather than the main trunk.
Exactly. Vascular, capsular ligation, isn't it? The branches of the inferior thyroid artery are ligated closer to the thyroid capsule. So the serve the parathyroid vascularity. Okay, that's what you do.
Yes, sir.
Okay. What is the vascularity of the parathyroid glands? What is the main arterial
inferior thyroid artery.
100%? 100%
Yes.
inferior thyroid artery?
Sir, very less from the maximum supply is from the inferior thyroid arteries only.
Yes.
Very less proportion it is from the superior.
Superior parathyroid gland, maybe 15 to 20% may come from superior thyroid artery. So as the majority of the more than 80% of the blood supply is from inferior thyroid artery.
Inferior.
Okay. At this point, I think I will wait for some others can ask any doubt. I have otherwise I will. Anybody first? You want to continue? Okay. Then
so what you are planning for this case?
Yeah.
What you are planning for this case?
Sir, total thyroidectomy.
Why do you want to total thyroidectomy?
Sorry, sir.
Why you want to do the total thyroidectomy?
So the goiter is involving both the lobes of the thyroid.
Okay.
Both the lobes of the thyroid are involved.
So you want to remove the total?
Yes, sir.
Okay, Sneha. Now I think you did a total thyroidectomy. Okay. You are in the post-operative patient. Patient is still in the operating table. Huh? The patient, the anesthetist just remove the tube. Patient is having stridor on table. Patient is not taken out of the operating table. Just they remove the tube on table. Patient is getting stridor. What is stridor, by the way? Can you define stridor?
Sir, it is due to the compression of the trachea, which will because of the air gush of the air.
Compression of it. It is a high-pitched sound produced due to narrowing of the airways. Okay, high-pitched sound due to vibration of the stiffer soft tissues, soft tissues like the larynx, trachea. Okay. What is stertor? Stertor.
Sorry, sir.
Stertor. Have you heard of the term stertor? It is again low-pitched sounds produced due to narrowing of the soft tissues in the larynx. Okay. Not larynx, above larynx. Okay. So stridor, you may get inspiratory, expiratory, or biphasic. I am not going to the details. Okay. Patient is getting stridor on removal of the tube. What will you do? On table. Patient is not shifted out of the operating table. So what are the reasons you suspect at this point in time? You did a total thyroidectomy?
Because of the tracheomalacia, the patient might be having.
Yes, that's a good one reason, tracheomalacia. For that very reason, you have to palpate the trachea before you close the incision, especially in the last thyroid. Okay, tracheomalacia is one reason. Yes, what are the other possible reasons?
Bilateral injury to the recurrent laryngeal nerve.
Exactly, very good. Yes, anything else?
And the hypocalcemia, I can be said.
No. Hypocalcemia
it will manifest later.
It will take time. It's not. You can late stridor you can get, not immediately on table.
So laryngeal edema.
Wound. Will you see at the wound? Hematoma. I'll ask. Will you check at the drain? Will you look at the wound?
Yes, sir. Yes.
Okay, you can get that. What is paradoxical vocal cord motion syndrome? Okay, especially in some people who know something about the recurrent angina injury and post-operative injury and all. Some people, they anticipate this problem. It's called paradoxical. When the patient start to take deep breath, the vocal cord instead of abducting, they adduct. It's a little psychosomatic problem, and then you will be in trouble. Okay, so we can. So these are the problems. So what will you do? I think Kanakavel sir is asking us to close. Last couple of questions only. I will close with this. Suppose the patient.
Please go ahead, sir.
Yeah, sorry.
Please go ahead, sir. No problem. Couple of questions.
Okay, no problem.
I think Dr. Berylson has raised his hand. Okay.
Dr. Berylson, any questions from your side?
Hello.
Yeah, please.
Yeah. Dr. Neha, I just want to ask you some basic things. So whenever you plan for a total thyroidectomy to this patient, what is the position you place the patient? And can you tell me what are the layers you encounter from the skin to the thyroid?
Sir, I would like to give the Rhodes position for this patient. Starting from the skin, subcutaneous tissue, platysma, raising the subplatysmal flaps, then separating the fascia and separating the strap muscles apart, then reaching to the thyroid capsule. Sir.
How do you separate the fascia? How is your incision and how do you separate the fascia?
Incision will be the horizontal, sir, collar incision, and the fascia will be separated.
For the fascia.
For the fascia.
For the fascia.
For the fascia, when do you make incision?
What? Sir, it will be the vertical incision.
Okay. So then what do you do next?
Sir, then reaching to the thyroid capsule, starting the dissection with the middle pole of the thyroid and ligating the middle thyroid veins. Then the dissection can be separating the thyroid gland. The dissection can be carried out either in an inferior towards the inferior fold, ligating the inferior thyroid pedicle, and then on the same side, continuing dissection with the superior thyroid fold, ligating the superior pedicle, and then taking of the thyroid, lifting up the thyroid medially to go towards the opposite side of the thyroid gland.
So where do you see the recurrent laryngeal nerve when you are doing this dissection?
Inferior pole of the thyroid and the posterior laterally at the tubercle of Zucker-Candle, and morely at the Berry's ligament, sir, in the tracheoesophageal groove.
Okay. So can you tell me something about minimal invasive techniques which are in place now? Any clue about that?
Sir,
because it's a benign condition.
Minimally invasive video assisted thyroid surgery, which can be done either through a transaxillary route or a transoral route, sir, which are most commonly used nowadays. For a swelling which is less than 3 centimeter in size, or for a parathyroid adenoma, which can be performed.
Which are the 3 areas where you can injure the parathyroid, peripheral laryngeal nerve? Most commonly injured sites of peripheral laryngeal nerve during thyroid surgery.
Sir, near the Berry's ligament, at the
yes.
Berry's ligament.
Near the Berry's ligament, then your nerve goes into the larynx. Yes. Other areas? When you
at the inferior thyroid vessels.
Because the inferior thyroid artery and the peripheral laryngeal nerve are closely related. So when you ligate these branches, we have to take that. The third position is the inferior pole. What does the inferior pole of the thyroid contain? What does it contain?
Parathyroid glands are situated on the inferior pole posteriorly.
Parathyroid glands. What I say?
Any vessels, any structure is there in the inferior pole?
Inferior pole of the thyroid. What is the structure? You ligate the inferior pole, no? Before you take out the gland. What structure is there? But which vein?
Common vein.
What vein is there?
Jugular. You ligate jugular vein?
No, sir.
Jugular vein.
No, sir.
So it's there. Inferior pole. What vein?
What?
Inferior thyroid vein.
What is coccus?
You said inferior thyroid artery is coming from where?
Inferior thyroid artery is coming from the thyrocervical trunk.
This
is a branch of subclavian artery.
All the examiners are very friendly. They don't ask every time. They don't ask tough questions. Many a time they ask you very simple questions. So, okay, don't get tense up. Yeah. What is coccus vein?
Coccus.
Yes.
Sir, I don't know.
What is middle thyroid vein? How many percentage of patients you get middle thyroid vein?
30% of patients we can get a middle thyroid vein.
Yeah. Where does it join?
It drains into IJV, sir.
IJV, yeah. IJV. So coccus vein is somewhere in between the middle thyroid vein and inferior pole. You get in maybe 20 to 30% or you may get. Okay, that's coccus vein. Okay. Right.
When you are answering well, we will also ask about the triangles of the neck. Triangles which will come across the thyroid surgery. What is the rib space?
I think
Beer's triangle.
Jules triangle.
Okay.
So that is an anatomy. Okay. So in this case, after surgery, you are done total thyroidectomy. How you are going to follow up the patient?
Sir, first I would like to
follow
follow
the
for the in the first week, second week, and then after the after 3 months and the 6 months, sir.
Yeah, will you give any drug for that? Because you have removed the thyroid totally.
Thyroxine, sir. Yes, I would like to start the patient on the thyroxine.
How much?
Sir, 100 milligram OD, 100 microgram OD. Sorry.
So it is your wish, or you maintain, do something and measure something and do decide accordingly.
Yes, sir. Sir, measuring the TSH level. And
What
So
is
your
the
goal?
type of treatment of thyroxine treatment in this patient? This is a benign multinodular goiter. You did total thyroidectomy.
yes.
So what do you call this type of treatment of thyroxine treatment?
Supplemental thyroxine, which are given.
This is not supplement. You remove the thyroid.
Replacement. Okay.
What is the replacement dose?
100 micrograms OD.
No, 100 is suppose the patient is only 30 kilogram weight, or suppose the patient is 100 kilogram. Both will get 100 microgram only. Should be based on the weight.
You have a dose per kg body weight, or you calculate it is 100?
Dose, you can't say a blanket 100.
Suppose you are doing a surgery for a neonate. What is the dose of the thyroxine?
Sir, 1 to 2. I am not sure, sir.
No, please remember, for a thyroxine, for a pediatric neonatal, it is 16 milligram per kg body weight. But adult, it is 1.6 milligram per kg body weight. So almost 100 milligram per kg.
Replacement dose.
It's a normal dose.
1.6 microgram per kilogram body weight is a replacement dose. And if you are giving for suppression, it should be 2 to 2.2 microgram per kilogram body weight. You can remember almost more.
So there we have a
double the body weight for suppression.
Our role is to maintain the thyroxine level at what is the normal thyroxine level. I mean TSH level. When you are going for a replacement dose, you must keep in a normal. But if you are going for a suppressive dose, depends upon the score, whether it's a mild carcinoma, moderate or severe. Depend upon that, you maintain the dose for that. But one thing you must remember, like anti-snake venom, which we are giving a drug, here thyroxine dose is irrespective of the age. It is almost same to 100, because the dose requirement for the neonate is almost 15 to 16 milligram per kg body weight. Even if you have a 10 kg body weight or 5 kg, you get a nearly dose the same. For the neonate, pediatrics, and the adults, then the dose of the thyroxine is almost same.
Okay.
Okay, sir. I think we will stop, sir. Because Kanagavel, sir, I think second time with us. Thank you, sir. We'll stop.
Thank you, everyone.
Thank
Dr.
you,
Faiz Hussain, Professor Hussain, sir, do you have any questions?
No, sir. No, sir. Thank you, sir. Thank you so much.
Thank you very much. Dr. Sneha, do you have any doubts to get clarified?
No, sir. No, sir. No.
You want to make any comments? Do you have any questions or queries?
No, sir. I don't have any questions. Thank you so much, sir, for the opportunity.
Thank you, Dr. Sneha. And I think Dr. Shilpa ma'am is yet to join. Maybe you also give our thanks to Shilpa ma'am. I'll try to speak to her in the morning.
Okay.
You can stay with us for the next case. Depending on if you are on call, maybe you can leave. Otherwise, I will request you to stay for the next case.
Yeah, you did well. You did well. Okay. We need to be a little more organized. That's all. Okay. I think you know the stuff good.
Okay. Thank you, sir.
Thank you, Dr. Sneha. Can I request Dr. Subhash to share his presentation, please? Are you with us? Please unmute yourself, Dr. Subhash.
Sir, good evening, sir.
Yes, please start sharing your PowerPoint.
Yes, sir. So, one second, sir.
Do you have any challenges, Subhash?
Yes, sir.
Yes, ma'am.
Good evening, sir.
Subhash. Start with.
Thank you, sir. Good evening, sir. I am Dr. Subhash, finally postgraduate in GM Chemistry, Salem. and I'm presenting a case of locally advanced carcinoma right breast, sir. Yeah, 45-year-old perimenopausal woman. She's a homemaker by occupation, belonging to low socioeconomic status. Coming from Salem, came with the chief complaints of a lump in her right breast for past 8 months and a pain in the right breast for past 1 month. Still presenting illness. Patient was apparently normal before 8 months. Then she noticed a lump in her right breast while taking bath, which was initially small in size and was gradually progressed to attain the present size. And she was on treatment for the presenting illness in a private hospital for past 7 months, and she now admitted in our hospital for further management, sir. History of pain over the lump was present for past 1 month. Incidence onset is continuous in nature and it's not relieved by taking painkillers. And there was no history of any nipple discharge, no history of recent retraction of the nipple, and no history of trauma. No history of ulcer present over the lump, no history of swelling in the axilla and contralateral breast, no history of fever, history of loss of weight and loss of appetite was present, and no history of any bony pain, no history of any abdominal pain, abdominal distension, no history of yellowish discoloration of the eyes, no history of cough, breathlessness, and no history of headache, seizures, and focal neurological deficits. Past history. She's newly diagnosed as a type 2 diabetes mellitus, and she was on insulin for past 2 months. And it was not a known case of systemic hypertension, bronchial asthma, pulmonary tuberculosis, and epilepsy. And there is no history of similar illnesses in the past, and no history of any intake of the oral contraceptive pills and the previous radiation exposure. And treatment history: a patient is on treatment for the presenting illness for past 7 months in a private hospital, and she is on a neoadjuvant chemotherapy and completed 6 cycles. And the last cycle was 1 week back. And there is no history of a decrease in size of the tumor by history wise following administration of the chemotherapy drugs. Family history: there is no history of any breast, colorectal, ovarian malignancies in the family members, and pancreatic, prostatic malignancies in the family members. And personal history: she consumes mixed diet and bowel and bladder meats were normal. Menstrual history and obstetric history: she attained menarche at the age of 15 and married at the age of 18. She is para 4 and life 4. First child is at the age of 19 years, and she breastfed for 1.5 years for the first child, and the second child is at 21 years of age and breastfeeding for 1 year, and third child is at the age of 23 and breastfed for 1 year, and fourth child is at the age of 25 and breastfed for 2 years. And the LMP was 5 months back. Summary: a 45-year-old perimenopausal woman presented with lump in her right breast for past 8 months and pain in her right breast for past 1 month. She completed 6 cycles of neoadjuvant chemotherapy and now admitted for further management. General examination. Patient is comfortable at rest.
Your history.
What is perimenopausal?
Yeah, that is the question I want to ask.
What do you understand by perimenopausal?
She had the perimenopausal patient is having LMP is like 5 months back, sir. And, up to 12 months, the patient is in perimenopausal, sir. If the patient is not having a menstruation for 12 months, it's a perimenopausal period.
But you said she had the LMP 5 months back.
Yes, sir.
Is that correct? Okay. If there is a family history of breast cancer is there, what are the things you are going to ask?
Sir, first, the degree of the relative who had breast cancer, sir, and what type, degree of relative who had cancer, and what type of breast cancer, and whether they have undergone any treatment or not, at what age they have succumbed for the disease.
No, but what specific things you are going to ask in the family history for the breast cancer?
At what age?
You ask whether the family member had a unilateral breast cancer or the bilateral breast cancer, or whether it appeared in the premenopausal or whether it appeared in the postmenopausal.
Okay, sir.
So if somebody had a bilateral breast cancer in the premenopausal, he has got the highest incidence or chance of having the malignancy.
Okay.
So why you are so specific about breastfeeding the first child at 1 year and second 1.5 years and the third 2 years and then again 1 year?
Sir, exclusive breastfeeding for more than 1.5 years, 1.5 to 2 years is a protective factor for sir. And there is a less estrogen exposure to them, sir.
No, but you are telling about every child, isn't? And you specifically mentioned the 4. One was 1 year, another was 1.5 years, then 2 years and 1.5 years. Any specific reason for that, or it is just you are eliciting the history?
Sir, no, sir. During lactation, there will be the lactational ammonium, sir, and there will be less estrogen exposure to the breast.
No, that is all okay. Okay, anyway, it is not required to put that about every child that how much time the breastfeeding has been done.
Okay, sir.
You have put as your menstruation started at 15 years and the first child was 19 years. Is there any risk factor on that?
Sir, yes, sir. First, early menarche and late menopause is a risk factor, sir. There will be more estrogen.
Why early menarche is a risk factor?
So because the patient have more estrogen exposure to the breast tissues. They have the patient has early menarche, they will have more exposure.
Why? How you can suppose the patient develops the cancer at the age of 30, or sometimes somebody develops the cancer at the age of 50? Is it only the duration of the menstrual cycle is important, or anything specific for the early menstrual cycle? So early menstrual cycle, what type of cycle you get in early menstruation? You get anovulatory cycle. What do you mean by anovulatory cycle?
So there will be no ovulation, sir.
Why there is no ovulation? Because the pituitary, the hypothalamus pituitary tract is not well developed, so you will not have a LH surge, so you will not. So that you will have a continuously, you have a estrogen exposure. It is not only the number of cycles you are exposed. It is the duration in which totally your exposure is important. So what is the importance of the 19 years she is having a childbirth?
Sir, if the patient is having sir,
what is Gale's index? Gale's prognostic index.
It includes age of menarche, age of first childbirth, and so if the patient is having
so what is the protective age group? What is the protective age group? Or from what age group you will get the first childbirth is protective, and less than what age group you get a more?
The patient is having full-term pregnancy before the age of 21, it's a protective system.
So here the child, this patient has having a 19 years, he has a
19 years, yes sir.
So why it is so in the early childbirth pregnancy? What is the reason it is getting?
Sir,
what is why do you get the cancer in the breast?
Terminal duct lobe, sir.
Okay, what is the types of, how many types of terminal duct lobules you have? What is type 1, type 2, type 3? So you must know what is the what is happening in the pregnancy, what is the change which is happening in the terminal duct lobule. So that is a predictive factor.
Okay, sir.
And which terminal duct type 1 is more prone to develop for the malignancy. So how it is changing, you should know. And you asked for the history of trauma. Why do you ask for the history of trauma?
Sir, because one of the differential diagnoses for carcinoma breast, the hard lump in the breast is a traumatic fat necrosis, sir. If the patient
how the trauma produces a fat necrosis?
Because of trauma, there will be inflammation and there will be saponification of the fat, sir.
Inflammation will lead to saponification normally. So normally when you think of trauma, it produces a hematoma formation. And why it is producing a fat necrosis? Is it a single trauma, or what is the type of trauma you are expecting in a fat necrosis? It is not a single fall or single injury. It is a repetitive trauma which is getting. Somebody who is wearing a metallic bra with a metallic strip that can produce a continuous compression, continuous trauma. So what is the mechanism pathogenesis of developing a fat necrosis? What is the fat necrosis? What do you mean by fat necrosis?
So following trauma, there will be release of the inflammatory mediators, sir.
So we don't get that fat necrosis in any other area. Only in the breast you are getting fat necrosis. So from where you get fatty acid, where you get the calcification, where is the fibrosis is developing? It is a continuous trauma when the triglycerides, the fat release the fatty acid. When it is coming in contact with the capillary calcium, it produces saponification. So all that. So you should know the total pathogenesis, how it is the fat necrosis is forming, and what is the importance of the fat. That is you are going to talk about that.
Okay,
so
sir.
this patient at the age of 45, you are getting already he has come to you with 6 cycles of chemotherapy.
Yes, sir.
So why they are taken a 6 cycle of chemotherapy and coming to you? What is the reason they are coming to you after 6 cycle of chemotherapy?
So because history-wise there is no decrease in the size of the swelling, sir, after chemotherapy, 6 cycles of chemotherapy.
So normally, are you now suggesting this that the normal procedure that you are going to give the 6 cycles immediate to the chemotherapy and then assessing the case, or you will be assessing here?
So sorry, sir.
What is the protocol you are following in your institution? Are you going to give the 6 cycles continuously, then assess the patient, or you are going to give 3 to 4 cycles and then assess the patient?
So first we give for 3 to 4 cycles, sir, when we then reassess the patient and plan for surgery, and then give adjuvant chemotherapy.
So what is the chemotherapy they have used here?
So we are using artemisinin and cyclophosphamide AC regimen. If the patient is responding to artemisinin and cyclophosphamide, we are giving for 3 cycles, sir. And we are assessing the
Here I am asking for your patient. You are having a 6 cycle. Is the same drug is used or is the same drug is changed?
She was given chemotherapy in a private hospital, sir. First 4 cycles they were given artemisinin and cyclophosphamide, and fifth and 6th cycles they were given docetaxel, sir.
Taxane is used, but still there's no response. So non-response.
There is no response, sir.
No. What is resist?
Sir,
how will you assess the tumor responding to the tumor? I mean the chemotherapy.
So first, periodically we have to prior to chemotherapy, we have to assess first the size and the nodal status of the patient, sir. And after the chemotherapy, we again measure the size under the nodal status, and whether if the swelling is decreased in the size, there will be if it is decreased in the size.
So are you justified? Are you justified in giving a continuous chemotherapy for a patient for a 6 cycle where he is not responding to the same drug?
No, sir.
Okay, go ahead.
What is RECIST criteria or RECIST criteria? What is the full term?
Sir,
you know
sorry, sir.
What is RECIST criteria? You know what is RECIST?
No, sir.
Response evaluation criteria in solid tumors. Okay.
Okay, sir.
Now, can you tell what is the tumor doubling time for the breast cancer cell?
Sir, it's 2 to 9 months, sir.
2 to 9 months. That is too long, isn't it?
Too long and too short.
Yeah, too long and too short, probably. Yeah. It's approximately 100 days, and 80 to 120 days is approximate that. You know how much time does it take to make a 1 centimeter palpable breast lump?
5 years, sir. Approximately 5 years.
How many cycles? How many cycles? That corresponds to how many cycles? What cycle you will get the 1 centimeter tumor? And what cycle you will get the tumor metastasis? So you can get the tumor metastasis even at the 20th cycle. But when you get your 1 centimeter tumor, it is almost 29 to 30th cycle. So only when you're getting a 1 centimeter tumor, you're getting.
Okay, sir.
Do you know what are the various types of absolute conditions which can lead to malignancy, or what are the relative?
Sir, relative. Sorry, sir.
Absolute conditions for malignancy, predisposing factors for malignancy.
Atypical lobular hyperplasia, atypical.
No, we are not talking about history. We are talking about history, and we are taking a history of a patient, and what are the conditions will say that this is more prone to make develop a carcinoma. The Gale's index. What are the things that are modifiable?
Sorry,
relative and absolute. What are the factors which are absolute, and what are the factors which are relative? See, for example, the sex of the patient. The female sex is an absolute criteria for having a cancer. You cannot have a choice, but certain age you have a choice. So what is that absolute? What are the relative?
Okay, age of the patient, family history. No, what you said, the atypical ductal hyperplasia or atypical lobular hyperplasia.
Yes, sir.
BRCA, no, all those are the absolute one.
Okay, sir.
Or the patient herself had a breast cancer on one side. That is an absolute risk factor which is there. Okay. And others, all those like early menopause, early menarche and late menopause, nulliparity and all those, they are all the relative ones.
Okay, sir.
Can you tell what are the modifiable risk factors and non-modifiable risk factors for the breast cancer?
Modifiable risk factors are the obesity, alcohol intake, excess intake of the saturated fatty acid containing foods.
Why in alcohol it is a related modifiable risk factor? Why alcohol produces?
Sir, alcohol it induces more production of the estradiol from fat.
It doesn't produce more estradiol. It only makes it is more sensitive to estradiol, estrogen sensitive.
Okay.
Only the obesity produces most estradiol. If the peripheral conversion is taking place and most estradiol is taking place.
Okay, sir.
Can you tell what is the incidence of breast cancer in India and in USA?
Sir, incidence of
breast cancer in USA and breast cancer in India.
Out of 100, out of 1,000, how many people get the breast malignancy?
1 out of 1,000 people in India, sir.
No. And in USA? Okay, in USA it is every 6th or 7th woman in a lifetime is going to get a breast cancer. And in India it is 21 to 23 women in a lifetime is going to get the breast cancer.
Okay, sir.
Okay. Go on the examination now. Yeah.
So why
you can go on the
examination?
Finish off that.
Sorry, sir.
You have mentioned for the past 1 month she is having a pain.
Yes, sir.
How will you explain that?
Sir, patient is on chemotherapy, sir. She might have developed tumor necrosis, sir.
Tumor necrosis factor will produce pain?
Hemorrhage and necrosis, yes.
Okay. So, what are the other symptoms you will get in the tumor necrosis factor is there? Normally, TNF and IL-6 produce what?
Sorry, sir.
No, TNF and IL-6 normally will produce a pain and fever. They will have a constitutional symptoms will be also there. Okay. So here there is no constitutional symptoms.
Yes, sir.
So anything else you think of? So you say the size is not changing. When there is a tumor necrosis factor, usually the size will have to also have an impact on that.
Infiltration.
Somebody by the name of ESB, please mute yourself. ESB, please mute yourself.
Somebody
ESB, yeah, please mute yourself.
Kanagavel sir, can you have to mute that TSB? Okay. You can go ahead.
General examination after getting consent from the patient. Patient is comfortable at rest. Patient conscious and warranted to time, person, and place. IF febrile. Hydration was spare. Patient is moderately built and nourished. No pallor, no tic-tic, no sinuses, no clubbing, no pedal edema, no general sleep ability. And alopecia was present. And vitals, blood pressure was normal. It's 120 or 80 millimeter of mercury measured in a right arm in sitting posture. The pulse rate was 82 per minute, measured in right radial artery. It's a regular normal volume. Respiratory rate is 18 per minute. SPO is 98 in tumor, and ECOG score is 1. And the local examination, after getting consent with adequate exposure, patient on inspection, the patient in sitting position with the arms by the side of the body.
Subhas, we are repeatedly saying this word. Don't use the word local examination. You say what you are going to examine.
Okay, sir.
What is that examination?
Examination for both. The examination of both beds, sir.
Okay, so that you must specifically write that instead of don't write generalized assessment like a local examination.
Okay, sir.
Okay, go ahead.
On inspection, patient in sitting position with arms by the side of her body. Both breasts are asymmetrical. The right breast appears enlarged compared to the left breast. A lump of size approximately 10 cross 8 centimeter present, involving predominantly the upper inner quadrant and also the upper outer quadrant from 10 o'clock to 2 o'clock position. And skin over the breast, redness was present, and there was no engorged veins, no dimpling, no puckering, no PDR in the appearance, and no ulceration and fungation. And a nipple, right breast nipple is at lower level compared to the left breast. No fissure or ulcer, no retraction, no discharge from the nipple. An areola is normal in color and no crack, fissure, or ulcer. Arms and thorax, there is no swelling in the arms and no satellite nodules visible. And with arms raised above the head, the lump becomes more prominent and there is no PDR in appearance and no puckering, and the inframammary fold appears normal. On leaning forwards, both breasts falls equally, and right axilla there was no fullness noted, and the left breast appears normal, no fullness noted in the supraclavicular region on both the sides. On palpation, warmth and tenderness present over the lump, and a lump of size 14 cross 12 centimeter present occupying the upper inner and outer quadrant from 10 o'clock to 2 o'clock position, and uneven in shape with ill-defined margins and hard in consistency. Palpation, there is no discharge from the nipple, and no retraction, and the areola is normal, no tethering, no PDR in appearance. The lump is fixed to the breast tissue, and the skin over the lump is not pinchable. Sorry, sir, it's not pinchable. And on moving a tumor from side to side, there is no appearance of dimpling or tethering on the skin. There is edema present over the skin. There is a skin edema present over the lump. And on contracting and relaxing pectoralis major muscle, there is a slight restriction of the mobility present along the direction of the muscle fibers. On contracting serratus and latissimus dorsi, there is no restriction of the mobility, and there is no fixity of the lump to the chest wall. Examination of the both axillary lymph nodes. On right side, there is no clinical palpable lymph nodes. Left breast, on examination, it appears normal. There is no lump palpable. Spine, cranium, long bones, and sternum, there is no tenderness and abdominal swelling. Systemic examination, cardiac. Distributive movements are equal on both sides, bilateral air entry equal. Per abdomen, it was soft, there is no distension, no organomegaly, no free fluid, and bowels and plus. Central nervous system, no focal neurological deficits. Diagnosis, it's a case of a locally advanced carcinoma right breast. TNM staging YC34B N0MX.
How do you test fixity to the latissimus dorsi? You said the serratus anterior and latissimus dorsi.
Sir, I asked the patient to push against with stretched hands, push against the wall, sir. By that, the serratus anterior muscle will get contracted, and we have to assess the mobility. And latissimus dorsi, I have to ask the patient to, in sitting posture, ask the patient to abduct the arms against resistance.
What is the relationship of your swelling to the serratus anterior and latissimus dorsi? You said it is the upper inner quadrant and the outer quadrant. Is there any relationship with the serratus anterior? Any relation to the serratus anterior?
Yes, sir. Upper outer quadrants will involve pectoralis major and serratus anterior muscles, sir.
No. Why do you want to do the serratus anterior test here?
If
serratus anterior,
if the lump is infiltrated into the serratus anterior, staging will differ, sir. Infiltration into the chest wall.
No, we don't expect upper swelling to enter into the serratus anterior. Serratus anterior do not come there to get into that. You have only the pectoralis major. And you said edema present. That means you have a PDH or edema. What do you mean by edema present?
So, there is no appearance of the PDRN, sir. Only edema, skin edema was present.
How do you get edema with, what is that edema and PDRN? What is the difference? So why do you get edema and why do you get in PDRN?
So both are due to the infiltration of the subdermal lymphatics, sir.
Okay.
Infiltration of the tumor to the subdermal.
Then why you are getting PDR? Normally, why do you are getting PDRN?
So infiltration of the subdermal lymphatics will cause
Shivas, my question is, you said there is already edema. You are saying there is no PDRN. So can you get a pure edema in a breast, and what is the reason? And why you are getting a PDRN is what is the reason? PDRN is also subcutaneous edema.
Yes, sir.
But what is the difference? Why you are getting a PDRN appearance? It is an inter-hair follicular edema where the hair follicles is going down to the dermis and deep to the subcutaneous tissue. That area cannot be elevated, so that produces the quilting effect. So only you get an edema in between the inter-hair follicular area. That will typically present as an PDRN. So you cannot have an edema alone. Just that the breast has a hair follicle, you will only have a PDRN. Either you have a PDRN, even you cannot say that it is an edema.
Okay, sir.
What other lymph nodes did you examine?
Sir?
Did you examine any other lymph nodes in this patient?
Sir,
you told about the axillary nodes, you told the supraclavicular. Any other lymph nodes did you examine?
So exam for the right side and left side axillary nodes, both supraclavicular nodes and
what are the other nodes which only like in this area it's in the
internal memory.
So how will you find the internal memory nodes?
By percussion over the sternum, sir, by direct percussion, I can't be able to appreciate any because of the
sternum. Percussion over the sternum.
No, it's intercostal area.
It's in the sternum. So are you going to palpate the percuss on the sternum or any other area?
No, it's in the intercostal areas.
Parasternal area, no?
Parasternal, okay. Parasternal areas.
What parasternal space? Which intercostal space?
There is 3, 4, 5, sir.
Okay. So as we have the supraclavicular, do you have any some other lymph nodes which are there? As we have the supraclavicular.
Yes, sir.
Do you have any other?
So deep cervical nodes, level 4 nodes.
No. As supraclavicular is there, similarly there is a
infraclavicular nodes.
Yes, infraclavicular. So that also has to be, you have to tell about that.
Okay, sir.
Did you examine the abdomen of this patient?
Yes, sir.
For what?
To root metastasis, liver metastasis, for finding any free fluid in the abdomen and any swelling. In case of a premenopausal woman, then we Kuchenberg's tumor, sir.
It cannot.
What is the mechanism you get a? What is the mechanism you get a Kuchenberg tumor?
Sorry, sir.
How do you? Why do you get a? I mean, what is the mechanism of getting a Kuchenberg tumor?
So it's a transilome.
Why you are getting only in the premum?
So because of the
Transilome.
ovulating woman only will get the metastasis. Sir.
Why? Why?
So through the lymphatic route, sir.
No, you are saying transilomic. Suddenly you are saying a lymphatic road. And what is the Kuchenberg tumor look like? How do you give the description of the Kuchenberg tumor? Is it unilateral or lateral? So 80% of the Kuchenberg tumor bilateral. What is the surface of the Kuchenberg tumor and how it will be feel like? No, you are partially right when you say the premenopausal. And what is the reason for why the premenopausal is not getting that kind, or not the postmenopausal not getting the Kuchenberg tumor?
In premenopausal, there will be ovulation, sir. The follicles will be active only in the premenopausal woman, sir. Ovarian follicles.
So we don't now advise the transilomic spread. The lymphatic is the most common because we don't get on the surface. It is only in the inside the tumor, the ovary you are going to get. It is bilaterally you are getting the tumor, and the surface will be always smooth. It's a fleshy, not a very hard tumor growth you are going to get. So the most common thing which you are getting, what is the commonest tumor producing Kuchenberg? Carcinoma producing Kuchenberg tumor.
Carcinoma stomach.
Yeah, it is not the carcinoma breast. The carcinoma stomach is more common in producing a Kuchenberg tumor than the carcinoma stomach.
Yes.
What is the first statement you are making? Both breasts are asymmetrical. What do you mean by that?
Sir,
so that
both
gives the impression that both breasts are pathological.
Sir, sorry, sir.
The both breasts are pathological breasts.
The right side is the pathological.
So you have to assume that its one breast is normal.
Yes, sir.
So then only you will be saying it is an asymmetrical instead of saying the both breasts are asymmetrical.
Okay,
Though
sir.
it is literally meaning is right, but normally we are meaning that one breast is normal and other breast is abnormal. So it is do not normally say that it's both breasts are asymmetrical.
Okay, sir.
And what is the staging you have made?
Sir, YC T4B N0M1, sir.
What the YC stands for?
So the patient have a neoadjuvant chemotherapy, sir. So we have to prefix.
So you are seeing a patient after
yes,
six cycles.
Yes,
is
sir.
it that your measurement at this stage is important, or what is the original stage is stands for?
Sir, the original stage is important, sir.
So how do you know the original stage?
So the original stage was for this patient. The original stage was T4B N1M1, sir.
So in the examination, what you are expecting is you are expecting the history of the patient. You are examining on that table.
Yes, sir.
So we don't want we do not know what is exactly the stage.
Okay,
at
sir.
that stage. So this is the stage where you are justified in saying the TX stage.
Okay, sir.
You cannot now put as a stage as a T4B.
Okay,
even
sir.
if that when we are knowing for sure that it is patient is under your care, you have made a diagnosis staging earlier.
Okay, sir.
So now the patient is coming you after somebody has made the staging, somebody has done a treatment, and it is coming to you. So this is the
Okay,
stage where you must put the staging under the TX. YC
Okay.
you can put only when it is under your care, you are following the case and you are putting that, because the stage is not going to change.
Okay, sir.
Whatever the treatment, even if it is responding to well, it is the same stage before the treatment is going to come.
Okay, sir.
So why you are want to put as a 4B at this time?
Because the skin over the lump was not pitchable, sir. I cannot move the skin over the lump, sir. So the skin infiltration is present. There is edema also present, sir.
What are the features of skin infiltration?
Pudor in the prints, ulceration, fungating growth.
No, you said there is orange appearance. You said there is no pudor orange appearance.
Skin edema.
There is no cutaneous nodules. There is no ulceration.
Edema also present, sir.
Edema can be due to the chemotherapy which you are giving, or any. You said it is already tender. I mean, warmth is there.
Sir.
If there's a cuticular lymphatic obstructed, that will only produce a pudor orange, not an edema.
Okay, sir.
Okay.
What are you going
So
to
how
do?
you are going to proceed?
Since the patient is on neoadjuvant chemotherapy and she has course of period for 7 months, sir. I will like to re-evaluate the patients for metastasis, sir. And first,
No, what is the response to chemotherapy here? What do you call that response? What are the various response to chemotherapy?
It's a complete responder, partial responder, sir. No responder. There is no response
this
to
patient fits into what?
Sorry, sir.
This patient fits into what?
Non-responders.
What is non-responder?
So, there is no decrease in the size of the tumor following the administration of the chemotherapy drug, sir.
How much is
So
that
that's
size?
7 months is gone. There must be a doubling of the time. Is you said it is only 6 months. So that means the tumors would have gone to the doubling of the size by the 7 months.
Okay, sir.
So there is no increase in the size of the tumor.
Okay, sir.
So will you call it as a partial responder or no responder? Ideally, this should be called as only a partial responder, because you say that the same staging, the size of the tumor is not increasing. Only when you have the 6 months time, you are definitely expecting the tumor to double the size.
Okay, sir.
And you are expecting that. That is not happening. So it is only considered the partial responder. You cannot put this as no responder. No responder, there will be, by this time, there will be at least 25% increase in the size of the tumor will be there.
Okay, sir.
Okay. So how you are going to proceed?
Sir, first I will do a routine blood initiation, complete blood count, sir. Because the patient is on chemotherapy drug, we have to, there is a combination of a bone marrow suppression. So we have to look for a leukopenia, anemia, and hemoglobin count, sir. And
that is only for your surgical purpose. Okay. And, so suppose it has a leukopenia is there, and what you will do?
We can give a granulocyte stimulating factors, fulgrestin, sir.
Fulgrestin. Okay. Oh. So now the patient patient is blood values are normal.
Yes, sir. Now she is her blood values are normal, sir, and the diabetic status also under control, sir.
Okay.
And I will do.
So what is the planning for that?
Sir, we are planning for a rise in modified radical mastectomy, sir.
You said N0.
Yes, sir.
So why do you want to do a modified radical mastectomy for a N0?
So because patient before starting the neoadjuvant chemotherapy, she had a axial lymph node enlargement, sir. And it is a locally advanced carcinoma. We have to do axial dissection.
So again, then you must be able to say only, then here you are putting as N0. That means there is a no node.
Clinically, there is no nodal enlargement.
So when there is no node, are you justified in doing an axillary dissection?
So we can do sentinel node biopsy, sir, and then we'll proceed with the axillary node dissection.
After 6 cycles of chemotherapy, okay, even then they are not getting the node. So then one aspect somebody will accept, but sometimes the examiners will not know. You need to go separately for the breast. What is the treatment for the axilla and systemic treatment? The treatment of the breast, if it is classified as a treatment for the breast, you are going to do what you are going to do. Axilla, what you are going to do. And then for the systemic therapy, you are going to do. Then that will be much better than just simply saying it is a modified radical mastectomy. Especially when you are specifically putting as an N0.
Okay, sir.
So you have done a radical dissection, modified radical dissection.
Yes, sir.
What are the things you look for? You are sending the specimen to the histopathology, and what are the things you will look in the histopathological specimen?
We have to look for the margins of the dissection, sir. Whether the margins are positive or negative, and lymphatic invasion, vascular invasion, sir. And in node, how many nodes we have removed and how many nodes are positive, and the grading of the tumor.
Why? Only that's all, or anything else you will also do? Well, whether you will be interested in doing the molecular classification?
Sir, we have to look for a ERPR status and NPM status.
Oh. So with that, so ERPR is positive, HER2 is also positive. The node is also positive. There is no node as per there, but clinically after that you have done axillary dissection, it is knowing that the 4 nodes are positive.
Okay, sir.
So how you are going to manage the case?
So we have to first start the patient. In this case, they have given already 6 cycles of chemotherapy, sir. And if it comes as a ERPR positive, we can start hormone therapy, sir.
I said there's a 4 nodes are positive.
4 nodes, we can go with the second line chemotherapy drugs, sir.
So which one you will start first? Chemotherapy or hormonal therapy first?
First, we have to start a chemotherapy drugs, sir. Chemotherapy should be started within 6 weeks, sir, of surgery.
The patient is also HER2 positive. So when will you start HER2 treatment? You will combine with chemotherapy or you will start it later? For a HER2 positivity, how will you start the treatment for the patient?
So after completing chemotherapy, you can start.
No. You will not wait for the chemotherapy to be complete. HER2 therapy is also a part of the chemotherapy. Then you can always start the chemotherapy along with that. Only then when you are using the adriamycin, then you have to be a little more cautious on using that.
Okay, sir.
Only the hormonal therapy you can start after that. So when will you start the radiotherapy?
So radiotherapy can be started after chemotherapy within 6 months, after 6 months.
So you have an option to start radiotherapy and chemotherapy. Which one do you start first?
The chemotherapy.
So chemotherapy
followed by radiotherapy.
So suppose it comes as an metastatic advanced tumor. You do the investigation. It is also showing the metastatic tumor.
So, metastatic tumors also will respond to chemotherapy drugs, sir. We can start chemotherapy.
No, this patient has a ERPR positive metastatic tumor, and what you prefer, whether you start on a chemotherapy or you start on a hormonal therapy?
Hormonal therapy.
Or what is the indication of starting chemotherapy in a metastatic carcinoma? when there is no visceral crisis. The first line of management of metastatic carcinoma is only as a hormonal therapy.
Okay, sir.
Among the hormonal therapy and chemotherapy. So chemotherapy is indicated only when you are having a visceral crisis.
Okay,
When you
sir.
have a liver cell failure, when you have a problem with that crisis situation, then you can start on chemotherapy. Otherwise, the first line of management is there. Suppose what are the newer advancements you are having in that breast management? Suppose metastatic breast carcinoma, this tumor is not responding normally to the radiotherapy. So what are the other options you have? What are the targeted therapy or immunotherapy or a gene therapy used for a patient coming with a metastatic breast carcinoma?
Sir, we can give a vascular endothelial growth factor inhibitors.
So you are not started studying on that. What is the MTAR? What is that program cell death inhibitor you are using? What is the regimen for a triple negative? So may not be for the initial stage, but when you are presenting the case very well, definitely we will be asking that more on the targeted therapy, immunotherapy, and also the last gene therapy is also coming to the vogue.
Okay.
So what are the various gene therapy methods you will be utilizing for the carcinoma?
Okay, sir.
Vash, can you tell about
Sir,
what are the components of modified radical mastectomy?
Sir, removing of the whole breast tissue along with the nipple area complex, sir, and axillary lymph nodes, level 1 and 2 nodes, depending upon the involvement.
And what are the various types of modified radical mastectomies?
Sir, 3 modifications are there, sir. Arch-and-clasp, patties, and scanlon, sir.
What is patties?
The patties in this pectoralis minor muscle is removed, sir, and the level 1 to 3 nodes are removed. In arch-and-clasp, the pectoralis minor is retracted and level 1 and 2 nodes are removed. In scanlon, the pectoralis minor is splitted its attachments and level 1 to 3 nodes are pectoralis minor is divided and the level 1 to 3 nodes are removed.
So in scanlons, from where you detach the pectoralis minor? What is the attachment of the pectoralis minor muscle?
It's a coracoid process of the scapula.
And coracoid process on one side, and on the other side. Okay, every muscle has got now nothing like the origin or insertion, but at least 2 attachments are there.
Okay, sir.
So one you said toward the coracoid process, second is on the ribs, no?
Sir. It's arising from 3, 4, 5. Sir.
Attachment. No? Now nothing like the origin and insertion now. In the muscles, sir. It's the attachments on.
Okay, sir.
Okay, so from where you will detach, in the case of the scanlon, from where you will detach the pectoralis minor? Will you detach it from the ribs or will you detach it from the coracoid process?
From the coracoid process, sir.
Coracoid. Now, what are the various nerves you encounter during the axillary dissection?
Sir, nerve to serratus and a long thoracic nerve bulb, nerve to latissimus dorsi, and intercostobranchial nerves, sir. And median lacto petroneus.
So, what are the nerves you are going to save?
Sorry, sir?
What nerves you are going to save and what nerves you can sacrifice?
Sir, we have to save a long thoracic nerve bulb and a nerve to latissimus, sir. We can sacrifice intercostobranchial nerves.
What about the pectoral nerves?
Sir, we have to save the pectoral nerves. Median pectoral nerve we should save.
To save the pectoral nerve. If you do not save the pectoral nerve, what will happen?
Sir?
If you do not save the pectoral nerve, what will happen? If you sacrifice the pectoral nerve, what will happen?
So there will be.
You know how the chest wall contour is made?
Costal ribs, intercostal muscles, and over that serratus anterior and
Contour. Okay, it is by the pectoralis major muscle.
Yes, sir.
So if you damage the pectoral nerves, there will be pectoral muscle atrophy will be there.
Atrophy.
Do you think the
Suppose
radical
pectoral muscle is involved, infiltrated, what you will do?
So we have to shave off the pectoral muscle, sir. Involved muscles.
When you shave off, what is the significance of the nerve supply to the pectoralis major? When you are shaving off, nothing is going to happen to the pectoralis major. Why? So where is the nerve supply for the pectoralis major comes? Significance of how do you identify the middle pectoral nerve? What is the vein which is coming there? How will you see that triangular shape? It is always coming from posterior to anterior. So whatever the muscles you are shaving off in the anterior portion, still the rest of the muscle will get the nerve supply. That is why you are justified in doing the shaving off of the muscle.
Okay.
What is the significance of the nerve supply to serratus anterior?
Now to serratus anterior, there will be winging of step.
Suppose you get the serratus anterior nerve is cut at the level of the fifth intercostal space. What will happen to the nerve? So serratus anterior, you must be very cautious because it comes down, then it ascends. After ascending only, it starts supply.
Okay.
So even if you are cutting at the level of the fifth intercostal space, the entire muscle will lose its nerve supply. So you need to trace that serratus anterior very carefully and identify the angular vein which is going to connect with the thoracodorsal. So that area, up to that, you have to be very cautious of the preserving the serratus anterior nerve. So lateral pectoral nerve normally we don't see. So we are preserving the middle pectoral nerve, serratus anterior, and thoracodorsal nerve.
Well, is the radical mastectomy is really a radical mastectomy or not? You know, Halsted mastectomy which is there. Is that a real radical mastectomy or not? You understand my question?
Yes, sir.
Is radical mastectomy, when we say like the classical Halsted mastectomy which is there, is it really radical or not?
So radical.
It is not radical, because it is not taking care of all the lymph nodes which the breast is draining. Now, whenever you say it's a radical one, means you are removing all the draining lymph nodes.
Okay, sir.
But that is not being done here.
Yes, sir.
Do you remove the whole of the pectoralis major in the case of radical mastectomy, or do you remove the part of the pectoralis major?
So the one overlying the breast is only removed, sir.
How many parts of the pectoralis major are there?
So 3.
Mainly 2 parts, clavicular part and the sternal part. So in between the clavicular head and the sternal head, what is the very important structure there? That is why you only remove the sternal part, not the clavicular part.
Okay, sir.
The cephalic vein is there.
Yes, sir.
So the cephalic vein which is there in between the groove between the clavicular and the sternal part. So if you damage that, there will be, what can happen if you damage the cephalic vein? A lot of the edema will be there, okay? A lot of the edema on the arm will be there if you damage the cephalic vein. And that is why you are only removing the sternal part and not the clavicular part.
Okay, sir.
Okay. If you damage the intercostobrachial nerve, what happens?
So there will be numbness over the medial aspect of the arm, sir.
Okay. Now, how do you prevent a seroma formation after the mastectomy? What are the various ways to prevent the seroma formation?
By keeping a suction drain after mastectomy, sir, and a tight compressive dressing, sir.
So do you keep a full suction drain, or you keep a half suction drain, or you keep without the suction drain? Out of these 3, which one is the best?
Half suction.
Usually the half suction drain. That is supposed to be. There are few papers which have shown that half suction drain which is there. That is one. Any other ways to prevent the seroma? putting any glues and all those things?
You must read a lot of recent advanced papers. Those lot of papers are coming on various techniques of preventing the seromas.
Okay, sir.
Application, not using cautery. There's a lot of papers are coming on.
Okay, sir.
Suppose it comes as a triple negative tumor. What precautions you will take? BRCA1 positive and it's a triple negative. What options do you have for that?
Sir, we can go we can do prophylactic mastectomy, prophylactic salpingopectomy, sir.
Why?
Sir, BRCA1, if the patient is having BRCA1 mutation, they have it's a hereditary cancer. The patients are more prone for developing a bilateral breast cancer, sir. So we can do prophylactic mastectomy.
The patient is at the 45 years old. So straight away you will do a prophylactic mastectomy, or you will do any test and then you will go. Is there any way you detect that, or you just go ahead for the prophylactic? Just because it's a BRCA1 is positive, you will go for a prophylactic mastectomy.
No, sir.
So any test can tell you about what the multicentricity, the lobes are involved. Mammogram, or you can do an MRI. That's an indication for doing an MRI, which can only when you are seeing. Suppose, is there anything called the lobular carcinoma in situ?
Sir?
Is there any entity called lobular carcinoma in situ?
Is it?
You have a ductal carcinoma, DCA you have, no? In situ ductal carcinoma. You have in situ lobular carcinoma.
Yes, sir.
Is there an entity? Okay. So what is that? Is it a primary condition? And what carcinoma develops in situ lobular carcinoma?
Sorry, sir.
Do the AJCC 8 talks about lobular carcinoma in situ?
No, sir.
So we don't now consider lobular carcinoma in situ, because lobular carcinoma will only produce a ductal carcinoma. It will not produce it will not turn into the lobular carcinoma. That it is not dependent to the predisposing or pre-malignant condition. So in the AJCC, you don't have in situ talking about the lobular carcinoma in situ.
Yes, sir.
Do you know what are the various...
Will surgery will be difficult or easier for this patient? Already done radiotherapy. Chemotherapy.
Surgery will be difficult only, sir.
Why?
Sir, because of chemotherapy, there will be more edema fluid in the tissue fluid. Tissue will be more friable. And the patient is having...
The chemotherapy will produce a friable tissue. If we are talking about radiotherapy, it is fine, but not the chemotherapy. Okay. Kanna sir, you can go.
Well, do you know what is a Holstedian concept for the breast cancer?
Local is a Halsted breast cancer is a local disease. First, it involves the breast and it respects to the node and then to the systemic metastasis.
And any other concept you know?
Fisher concept, sir.
What is that?
It's a systemic disease, sir. Patient will have sir.
Yeah, please go on. Yeah.
Patient will have a systemic disease. If the patient is presenting with lump breast, the patient will have a micrometastasis to the node and then to the under systemic disease spread, sir.
No, Fisherian concept is from the day one, it is a systemic disease. And that is why all those concepts of the breast conservation which has come is because of that.
Yes, sir.
And what is a spectrum concept?
Sorry, sir.
Okay, so neither the Halsted is correct nor the Fisher is correct. So breast cancer can metastasize just like the Halsted, or it can be also a systemic disease.
Okay, sir.
Yeah, both type of the cancer, that is called a spectrum concept, where both the models are correct.
Okay, sir.
Okay, can you do the breast conservation surgery in this patient?
So no, sir.
Why?
So because it's the lump is large compared to the breast tissue, sir, and it's at stage 4, stage 3 disease, sir. We cannot do breast conservation.
So if you are carrying out the breast cancer, like there is a small lump is there, let us say it is a 2 centimeter lump which is there in a big breast. So how do you do the breast conservation?
So we
How
do,
much are the margins which you are going to use?
so we have to give 1 centimeter margins.
All sides? What about the skin? Are you going to excise the skin or not?
So no, sir. We have to keep the, no, sir. We should not excise the skin, sir.
Skin is not excised.
Without excising skin, we will be able to do the breast surgery. Then how do you reach the mass? No, without excising the skin, how will you reach to the mass? You are going to do laparoscopic procedure.
The skin over the lump.
Only thing is,
skin over the lump
no,
is
skin over the lump has to be removed.
Yes, sir.
The area of the skin you are removing is going to be less. That
No,
doesn't mean that you should not say that it's a skin I want to remove. You will remove the skin only if it is confined to the mass region.
And then how do you label your specimen, you know? When you're doing a breast conservation surgery,
Sir.
You know, you have to find out that which margin is getting involved or not. So you have to label the specimen there.
For making the pathologist to identify that whether you are going to the superior
Whether it was
margin,
a lateral
or
margin or medial margin or superior margin or inferior margin or posterior margin or anterior margin.
Sir, by using a stapler, sir.
How the stapler will help in that? How the stapler will help in that? You will put the stapler marking there for the purpose of the giving the radiation. I am asking from the pathologist point of view.
So by taking superiorly, we have to tie short threads, sir, laterally long threads.
Short superior, long lateral.
Long lateral.
And how will you do the anterior and posterior? You know, if you have not removed the skin portion, okay, there's a deeper tumor is there, you have to just incise the skin. And you may not excise the skin.
Okay, sir.
Then how will you know where is the anterior and posterior? Double suturing, na? If you put the two sutures, then that suggests it is the anterior one. Okay.
Okay, sir.
If the skin is there, definitely that is the anterior one. But if the skin has not been excised,
okay,
then
sir,
you put the two sutures there.
Okay, sir.
Okay. Does this patient always require the radiotherapy or not? Breast conservation.
So the patient will always require radiotherapy, sir. It's a part of a breast conservation surgery.
It's a part of that, yes. Sure.
Radiotherapy to where? To the breast or axilla?
So radiotherapy to the breast.
Axilla?
So we have to do axillary dissections separately with this in a separate incisions.
No, if breast conservation surgery doesn't include axillary dissection. You can do axillary dissection, but you are not going to do it much. So if you are not doing axillary dissection,
you know, what are the various ways to carry out the sentinel node biopsy?
Sir, by injecting a methylene blue dye or by using a radionucleotide technician using gamma, and then by using gamma probe we can pick up the sentinel node, sir.
Any new
only
dye which
two.
can be used for that, yeah? Can you use any other dye which is there apart from the blue dye which is there?
Any nanoparticle?
Sorry, sir.
Any magnetic way? you do?
Okay, you can use
So
the
we
endosine.
should start reading the newer recent advances.
Okay, sir.
Endocyanin green is in. Nowadays, endocyanin green is being used almost for everything. It is being used. It's also used for a sentinel node biopsy also.
Okay, sir.
Now, one of the most important things now you tried is a nanoparticle using a ferrous, which will be picked up with the tumor much better than what you are doing in the technician scan. There's no need for a gamma camera. This
Okay,
you
sir.
can easily do. It's a nano. Okay.
You know what is liquid biopsy?
Sir,
See, normally biopsy we do with the tissue. Sorry, sir. What is the liquid biopsy?
Sir, we can do.
So, what you are going to assess in the liquid biopsy?
Sir, any circulating tumor cells within the blood cell by centrifuging.
Yes, yeah.
So, DNA components. No, you can, especially when you are doing the small cell carcinoma of the lung, where we are repeated biopsy is not possible. Then now the component of the liquid biopsy is coming into the big way.
Okay, sir.
Dr. Lal, can we stop now? Yeah, can we stop now? Yeah, I think so.
Yeah.
Sir, I am with you, sir. We can close.
Yeah.
Sir. Before that, we will give Subhash to give an opportunity to ask any questions. Subhash?
Sir?
Do you have any doubts to be clarified here?
Sir, no, sir. So thanks for giving me opportunities to find this opportunity. And
any other faculty here would like to give any comments before we close? All of them have gone dinner or Karnagaran sir, do you want to add something?
No, sir.
Thank you, faculty. Thank you, Bash, and I think Neha is still there. Thank you, Dr. Neha, for joining us. Thank you very much. And I thank all the students and faculty joining the YouTube also. We will call the session closed. Next week will be mass abdomen session. If anyone has any mass abdomen case, you can reach out to me for presentation for the next. Thank you very much. Good night, sir. Jailal sir, Panna sir,
Thank you, sir.
Karnagaran sir.
Thank you.
Good night, sir.